I see that people are still joining, but I think we can get started. So hello, everyone. Thank you all for joining the day one of the NIA workshop on oral health and Alzheimer's disease. I'm Mariam Gale, and I'm a program officer at the Division of Neuroscience of the National Institute on Aging. And on behalf of the workshop planning committee, it's a pleasure to welcome you to this workshop. So before we start and dive into science, I would first like to thank the members of our planning committee. Dwayne, could you please share the slides? Don't see the slides. All right, okay. That's okay. So I would like to thank the members of our planning committee, Dallas Anderson, Camille Pottinger, Maya Marek, Mac Makewitz, and Damali Martin. And I would also like to thank our IT team and the Avanti team for their support in running this workshop. And of course, a huge thank you to our session chairs and all of our speakers. Now I would like to invite Dr. Richard Hodes and Dr. Elieza Maslia to provide welcome remarks. Dr. Hodes is the director of the National Institute on Aging, and Dr. Maslia is the director of the NIA Division of Neuroscience. And it's a great pleasure to welcome Dr. Hodes and Dr. Maslia. Dr. Hodes.
Thank you, and good morning. Welcome to this meeting on oral health and Alzheimer's disease and related dementias. This is really a convergence of two very important public health imperatives, that of oral health and that of Alzheimer's and related dementias. And most specifically, explores the great deal of interest there is in the potential role of oral health, in fact, as a risk factor for Alzheimer's related dementias. A risk factor, and importantly, a potentially modifiable one. We're delighted to be partnering with NIDCR, and in fact, to look forward to our plenary this morning from Dr. D'Souza, the director of that institute, and over these next 2 days to a lot of exciting science from the perspectives of our two institutes converging in this important area. I thank you. Maybe I turn it over to Eliezer for additional comments.
Thank you, Richard, and thank you, Mariam and Damali and others at NIA for organizing the meeting, and all of you for attending. The meeting is really a very exciting topic to us. I mean, we're well aware that oral health is a very important component of the aging process that could impact in negative or positive ways, depending on how you think about it, cognitive performance and brain neurophysiology. And I mean, it's also an area relevant to our interest on the environment interactions with genetics and aging, in aging and Alzheimer's disease and related dementia. So this is a very important topic to us, and we look forward to stimulating discussion and to learn a lot in the next couple of days. And again, thank you very much for all of you for being today. Thank you. Mariam?
Thank you so much, Dr. Hodes and Dr. Maslia, for the wonderful welcome remarks. Let me share my screen now. Okay, so just a couple of logistics in overview of the agenda before we start. And again, here is our workshop planning committee members. I would like to thank them again. Okay, so the goals of the workshop today and tomorrow is to understand the association between oral health and Alzheimer's disease and related dementias, is to identify research gaps and opportunities, to inform scientific priorities, to determine possible future directions for research in this area. And over the next 2 days, we will have 2 plenary sessions, one today and one tomorrow. We'll have a session on epidemiology of oral health and Alzheimer's disease, and a session on biology, mechanisms, oral microbiome, and Alzheimer's disease today. And then tomorrow, we will have a session on global perspectives on oral health and Alzheimer's disease and related dementias. And just as important, tomorrow afternoon, we will have an interactive breakout session. And we hope that you can all stay for this last part of the workshop and participate in the breakout sessions because this will be an opportunity for you, especially if you're not a speaker, to get engaged in the discussion and add to the dialogue in this field. So for this breakout session, we will address 4 questions, and I would like you to start thinking about this now. First question, what is the current data and existing research in the field of oral health and Alzheimer's disease? How strong is the evidence and what are the major challenges? 2, how can we optimize existing infrastructures such as epidemiology cohorts, research consortia, and animal models, and or leverage big data to investigate oral health and Alzheimer's disease and mechanisms through which they operate? Question 3, what analytic approaches or other research methods, additional data elements, and tools will be needed to advance research for oral health and Alzheimer's disease? And the last question, what concrete opportunities should we consider to accelerate a trans and multidisciplinary approach to studying oral health and Alzheimer's disease? What unique collaborative opportunities should we consider to enhance cross-cutting research in the field? Next. Okay, so in just a few housekeeping remarks. If you're not a speaker, please stay muted and turn off your video during presentations. If you have a question, please wait until the Q&A and please use the raise hand function to ask any questions or give comments or put your questions and comments in the chat. And please wait to be acknowledged by the chair when you raise your hand for any questions or comments. So this meeting is being recorded and we're also taking notes and the recording and workshop summary will be disseminated after the meeting. Presentation slides can only be shared at the discretion of the speakers. And again, I would like to thank all of our presenters. Thank you so much. Without you, this workshop wouldn't exist. And I would also like to thank all of our participants. And I will now stop sharing my slides. And okay. So now, without any further ado, I would like to welcome the chair for our keynote session, Dr. Stephanie Chamut. Dr. Chamut is an instructor in oral health policy and epidemiology at Harvard School of Dental Medicine and a 2021-2022 Health and Aging Policy Fellow in the American Political Science Association Congressional Program. Dr. Chamut is an advanced graduate education program, dental public health course director and co-director, a curricular evaluation lead at the National Center for Equitable Care for Elders, and co-PI of the HRSA grant title Catalyzing Oral Health Workforce for Rural and Vulnerable Populations, which created the first and only dental public health residency in the country with a dedicated rural track. In addition, she is part of the Human Resources for Health program, faculty at the University of Rwanda School of Dentistry, and visiting lecturer at the University of West Indies Mona School of Dentistry in Jamaica. Dr. Chamut.
Thank you very much, Miriam, and good morning, everyone, and thank you very much for your interest in attending this workshop. And it is my pleasure to introduce today's keynote speakers. First, Dr. Rina D'Souza. She's the director of the National Institute of Dental and Craniofacial Research. She oversees NIDCR's annual budget of more than 475 million, which supports basic, translational, and clinical research in areas of oral cancer, oralfacial pain, tooth decay, periodontal disease, salivary gland dysfunction, craniofacial development and disorders, and the oral complications of systemic diseases. As a licensed dentist, Dr. D'Souza is recognized for her research in craniofacial development, genetics, tooth development, and regenerative dental medicine. Prior to joining NIH, Dr. D'Souza was the Assistant Vice President of Academic Affairs and Education for Health Sciences at the University of Utah, Salt Lake City. She also served as a professor of dentistry, the Ole and Marty Jensen Chair of the School of Dentistry and Professor of Neurobiology and Anatomy, Pathology, and Surgery in the School of Medicine and the Department of Biomedical Engineering. In 2012, Dr. D'Souza was selected to be the inaugural Dean of the University of Utah School of Dentistry. She's devoted mentor and champion of diversity in the biomedical research workforce. And since then, in 1995, she has served as a volunteer dentist for women in need in people struggling with homelessness in Salt Lake City, Dallas, and Houston, Texas. Dr. D'Souza received her bachelor's degree in dental surgery from the University of Bombay, India, and after she completed her general practice dentist residency. She earned her DDS, PhD, and master's degree in pathology, biomedical science from the University of Texas Health Science Center in Houston. Also, we have Dr. James Noble. He's an associate professor in neurology in the Department of Neurology in the G.H. Trubisky Center and the Tau Institute of Research on Alzheimer's Disease and Aging Brain at Columbia University Irving Medical Center. His clinical research, outreach, advocacy, and education efforts are focused on life course modifiable risk factors of cognitive aging and improving awareness of neurological disorders. He's the clinical core leader of the Columbia Alzheimer's Disease Research Center and directs several large programs funded by the National Institute of Aging. He's also the co-editor of the 14th edition of the standard text Merits Neurology and author of the Caregiver Handbook, Navigating Life with Dementia, from Oxford University Press, American Academy of Neurology, 2022. Most relevant to this program, he's the co-editor of the WECAP ancillary study of oral health, which is a longitudinal study of periodontal infections and Alzheimer's disease on RO1. And the study aims to comprehensively and longitudinally characterize the periodontal and cognitive aging trajectories of more than 1,000 community residents using clinical indicators and multimodal biomarkers of both diseases. I welcome our keynote speakers and thank you for attending this presentation. Dr. D'Souza, the floor is yours.
Is Dr. D'Souza here yet? It seems like she has not joined yet. So maybe we can start with Dr. Noble. Are you ready, Dr. Noble?
Yeah, sure. I can.
Awesome.
Thank you.
Okay. All right, can everybody see my screen? All right, I want to first start by thanking the organizers of this program for putting this together. I will just share that I've tried presenting my work at a lot of different conferences, ranging from those covering the microbiome, Alzheimer's disease, neurology, and even dental conferences. And I've always felt a bit like a sore thumb at these conferences. And so it's wonderful to be central to what seems to be a growing level of interest and expanding number of investigators into this important line of work. So as Stephanie shared earlier, I'm an associate professor here at Columbia University. I'm the clinical core leader of our Alzheimer's Center. And over the last 15 years or so, I've been at work trying to better understand potential links between Alzheimer's disease and oral health. I have a slide here of my disclosures. I have no relevant conflicts of interest, but I just want to celebrate the support that the NIA and other NIH organizations, institutes have given me over the years. And most recently, the R01 study funded, as mentioned up top, we are currently undertaking a longitudinal study of periodontal infections and the potential association with Alzheimer's disease in the Washington Heights Inwood Columbia Aging Project, and I'll be talking at length about that later on. So my aims today are to briefly review Alzheimer's disease, its epidemiology and pathobiology, and periodontal disease epidemiology and pathobiology, anticipating our audience may have some expertise in one or the other, and to make sure that we're bridging any gaps in knowledge there. And I'll cover what associations have been established between periodontal disease and cognitive aging and decline. And as I mentioned, I'll turn later to some of our work that we've been undertaking in the Washington Heights Inwood Columbia Aging Project, and what findings we have and what we're up to for the next steps. As a trained epidemiologist, and this was actually one of my first grants, was my epidemiology training program that was funded by the NINDS. Central to the field of epidemiology, especially when one is venturing into potential new associations, one thinks of the Sir Austin Bradford Hill criteria, or known as the Hill criteria, which have these 9 core principles in trying to understand if an association may be worth pursuing or how to better understand it. And I've, as I mentioned, a lot of the work that I've been doing as presented often stands out as a sore thumb, and one has to wonder, okay, are we approaching this correctly, or how can we make sure that we're doing this on a scientifically strong ground? And so I've often thought about the Hill criteria and trying to understand some of these relationships and making sure that we're moving the science forward responsibly. But I want to start with a case discussion, as I think is always good practice to understand, why do we get inspired by this? And I think we can look no further than the original case description of August D., who was Dr. Alzheimer's patient himself. And in the case records, I found that he even described that she had dentures. So even the index case of Alzheimer's disease had periodontal or some other oral health problem. But coming back to reality here of where we are with Alzheimer's disease now, our estimates continue to evolve of the impact of its epidemiology, but we know that it is an exceptionally common disease among aging populations. Estimates continue to increase as our population ages, but currently we think around 6.5 million Americans have Alzheimer's disease. More may have a related dementia, and we think that Alzheimer's disease is maybe the 7th leading cause of death for adults and the 5th leading cause of death for those age of 65 and up. Those may be also underestimates, considering that it may be underreported in many cases. We know that from large epidemiological studies that about 15% of persons over the age of 65 will develop Alzheimer's disease, and it's about 45% of persons over the age of 90 have prevalent Alzheimer's disease, and those numbers go up with increasing age. It is an exceptionally long disease with a very long prodromal and pre-prodromal phase. Typically, we see symptomatic phases in our practice lasting 5 to 15 years, and we can identify pathobiological changes 10 to 15 years before that. And there is new evidence emerging that there's a pre-pathological phase, that is before we actually see anything on histology or advanced stains, but we know that there are multiple pathophysiologic mechanisms at work 10 to 15 years before that. So in sum, we're looking at a disease that may be as long as 20 to 40 years long in its development, suggesting that it's important to think about midlife or recurring or long exposure risk factors in this very long latency disease. It's also important to think about how it may operate at different phases of life too. And one of the things that's been central to my work over the while has been understanding health disparities, and definitely periodontal disease represents an additional health disparity. And it's important to think about how this disease may manifest or be present in different populations. And it's not just about the disease itself, but improving access, awareness, and care delivery. As I mentioned before, Alzheimer's disease is a complex pathobiology. We currently define it on 3 canonical diagnostic biomarkers, the so-called ATN pathway. There is an additional inflammatory or X factor we think about, but this is a very limited view of what is probably a much more complex disease, which by some estimates may place this somewhere between 10, sorry, somebody's marking up my screen there, that's not me, between 10 and as many as 50 biological indicators, including as evidenced by clinical imaging and lab changes. We can see also that there are generally probably 5 categories that we can think about with sequential problems that emerge over time. And the ones that I have underlined here have been at least somewhat associated with periodontal disease, whether it be epidemiologically or biologically. We know that it begins in its earliest phase with the development of amyloid plaque. We see synaptic changes in oxidative stress, leading to white matter and axonal integrity changes, immune activation and metabolic failure, and last stage is cortical atrophy. And we start to see cognitive impairment at right around that third bullet, maybe a little bit before, but definitely more apparent over time. It also has features including a complex genetics, including 3, maybe 4 causal factors in early onset cases, but about 5 dozen risk alleles in those with later onset disease. So one way to think about understanding life course risk factors for things like long latency diseases like Alzheimer's disease is to consider where these changes may occur, because they can also help us inform what strategies we may want to think about also for public health interventions. But a nice tool that I have used from time to time is something called a population attributable risk, or also known as a population attributable fraction, also known as an etiologic fraction. And it generally takes into account the proportion of disease and its relative impact on disease expression. Can somebody delete that mark there? I don't know how to do that, but I did not introduce that red line there. Somebody else on the call did. Anyways, if we think about the earliest population attributable risk, it begins with education, which may represent as much as a 7% modifiable impact if we believe that there is a direct causal link between education and another factor. We can think about other factors, including things like hearing loss, traumatic brain injury, and so forth, that occur over midlife, and other factors that occur in later life. There are several factors here, and I just highlight 3 in particular that are associated with systemic inflammation, which we think is probably a key component to periodontal disease as well. And these include smoking, diabetes, and inactivity, which are clustered here in later life, but are really midlife and longitudinal exposures too. And it begs the question, at some point, should we start thinking about adding periodontal disease to this list? Some key features here are that it's chronic, it's episodic, it's progressive, although it does end when someone becomes edentulous, and it does become worse with age. So it may not just be something that we think about as a later life issue, but throughout the life course. And one key feature here that keeps coming up is that even when we take into account all of these modifiable risk factors, fully 60% of the risk of developing Alzheimer's disease remains uncertain. So there's a lot of work left to be done here. When we turn back to the Hill criteria, we can think about what's already been established in the associations between periodontal disease and Alzheimer's disease and related dementias. We can think about temporality or exposures, in that we know that periodontal disease is associated with a frequent transient bacteremia, even with routine dental care in healthy persons, and it occurs across the lifespan, as I mentioned a moment ago. There's a gradient of exposure relative to the clinical severity of periodontal disease, and there's a detectable bacteremia that's common and becomes more common in those persons who have severe periodontal disease. That detectable bacteremia releases a whole host of responses in the host itself. We know that there's an inflammatory cascade, which will be talked about at length later on in this panel, but we also know that there are antibacterial properties in the brain itself of amyloid. We also have direct evidence that's evolved, and we'll hear from Dr. Domini and others later on today about the potential relevance of direct involvement of the brain itself, as well as in spinal fluid, and leading to an experiment of possibly treating these exposures, although we don't have a strong signal to suggest that's the approach just yet. For those of us who are not dentists on the panel here, just as a brief review of periodontal disease, it is unique in, as we talk about a lot about microbiomes, we think about the oral, the gut, the skin microbiome, but it is unique in that it represents a chronic biofilm infection. There's a commensal microbiome that is present, but it can evolve in the context of inattention to care. As the gums recede and the underlying bone is reduced, the upper part of the root appears. This erosion makes the gum line recede and makes the teeth appear longer. So this notion of getting long in the tooth is a chronic sequelae of low-grade and chronic periodontal disease. And in its end stage, the teeth become loose and avulse. We know that in the chronic indolent stage here, we can see pictures of gingivitis where there's redness, bleeding with brushing and flossing. The good news is this is a treatable and reversible condition, although it does recur often and can lead to chronic changes as an accumulative burden. Turning to its epidemiology, periodontal disease is the second most common cause of tooth loss, with the first being caries. Both of these can be acute diseases and have similar risk factors, including inattention to oral hygiene. Periodontal disease is exceptionally highly prevalent, with some estimates, including some of our studies that we've looked at, suggesting it's prevalent in as high as 75% of adults in America, and the epidemiology varies with definition and age. It is a health disparity, more often affecting men, disadvantaged populations, including race ethnic minorities, aging populations, and those with low education. And as I mentioned before, it is an exposure that begins really throughout the life course and as young as 2 years. And there are some studies of teenagers and the microbiome that's already evolved by then. It's associated with frequent transient bacteremias, as I mentioned, even in routine dental care in healthy persons and more often in those with periodontal disease. And it leads to a low-grade chronic systemic inflammatory state, which will be discussed later on today. Earlier studies prior to explorations into Alzheimer's disease and related dementias suggested an increased risk factor of periodontal disease on the later risk of coronary disease, stroke, and premature delivery of babies. So how do we measure this? And this is a key component that I think is going to come up again and again, and we need to make sure that we get this right. It is not adequate, really, to just ask people about their oral health. We know that oral health questionnaires poorly predict the current oral health state. It becomes worse with chronic assessments, and there may be some exceptions to this rule in that people can generally count the number of teeth that they have, they can report that, whether or not pain is present, and they can tell you whether or not they have no teeth at all. But really, with those exceptions, an assessment of one's own oral health is relatively poor to the objective measures. A whole mouth examination is burdensome. There are 32 teeth, there are 6 sites per tooth. There are functional assessments that can be taken after those counts and assessments are done, but it is very time and resource consuming in order to do that. But it may be the highest yield to do so. We know that it's also important to sample the oral microbiome, and there are different sampling methods that can be considered, including a single or pooled sample versus multiple samples and a salivary sample too. And it's also important to be able to anticipate the future, because even over the course of our work that we've been doing in the Washington Heights study, there have been 3 different definitions of how we define periodontal disease. And there is a crosswalk that's been established to understand how these may relate, but it's important also to be able to identify these X factors, these modifiable factors that may associate with grade of disease. Over the course of the last few decades, there have been evolving concepts in microbial etiology of periodontitis, really with key concepts being that there's a local and intense inflammatory and destructive process, which is tied into a staged and progressive dysbiosis, with the most virulent pathogens being at the peak of this pyramid, which was originally proposed as a grouping of different microbial complexes by Sokransky some decades ago, and has evolved into this idea of a pyramid complex. Interestingly, Sokransky himself, back in 1970, began to suggest many of the different pathways that we're thinking about now. And more recently, and we'll hear about this later on, is this notion of a keystone pathogen. That is, once one pathogen becomes present, does it change? Is it really central to changing the entire microbial profile of the mouth and of the patient? But this may just be a part of really what we're looking at. So the pyramid may be really just kind of a tip of the iceberg as we think about, because with more recent modeling, including 16S RNA sequencing, we can characterize nearly 800 different bacterial species, and many of these remain uncultivated. So we don't really understand their function entirely as a result, or how often they may be present. But these really high throughput sequencing approaches have underscored that this is a very, very complex pathobiology here. It's also important to realize that we can't just sample away the saliva. We know that the saliva and the oropharynx and periodontal pockets have very different unique microbiomes. And again, the periodontal pocket may be the one of greatest interest, considering that is the one that is a biofilm infection. It's also important to embrace new technology, but also new challenges, in that we understand that there is a multiplicity of relationships and comparisons. And as we've talked about this pyramid or the iceberg comparison, the keystone analysis, we also know that there are different ways that we can think about how different organisms are related when present. Should we think about proximity from an archaeological perspective, or more from a population functional microbial relationship? We can start to get at that with metagenomic analyses of the microbiome. This was a kind of a summary figure that I put together about 10 years ago, which tried to embrace all of these notions together and what is most interesting to us. I think a rather straightforward finding would be that individuals with cognitive impairment probably have an inattention to their own oral health care, which may capitulate other factors, including worsening caries and periodontal disease. But the direction that I became most interested in, that is, I think, why we're all here today, is it possible that these factors like periodontal disease, tooth loss, and maybe some other intermediaries here, such as this proposed association with masticatory inefficiency, or maybe a secondary adverse diet which follows, could all of these factors, especially a host inflammatory response and atherogenesis that follows, could these actually be central to cognitive impairment and maybe eat away at that 60% that we don't yet know? So with that in mind, I've been very focused on trying to understand, how do we better understand these potential relationships? This, again, beginning with my master's thesis work. This was my master's thesis that was later published in the Journal of Neurology, Neurosurgery, and Psychiatry. And for the first time, we found an association between P. gingivalis systemic antibodies and memory impairment on a cross-sectional basis. And these relationships at the highest levels of P. gingivalis held even after controlling for most other conventional risk factors for cognitive impairment. We then turned to, again, trying to efficiently understand these relationships. And we began looking at the Washington Heights and Columbia Aging Project for those individuals who had been enrolled in roughly 1999. And we had about 1,100 people with follow-up. And at that time, in 2010, we were able to select 128 incident cases and controls at the last follow-up known, match them on race, ethnicity, and ultimately come up with what was called a case cohort study, not a case control study, but a case cohort study, which takes time into account. And so we were able to identify which individuals developed dementia, which ones were still relatively healthy, and look back to their periodontal antibody profiles some years before. And although we didn't find the same associations as what we found in NHANES, we did find associations between essentially two of the primary 11 antibodies that we looked at, including Anas lendia and inodatum. Not to say we fully understand these relationships, but it does seem to be that there's a complex relationship at the systemic level when we're looking at incident dementia and periodontal antibody responses. So again, underscoring this is not just a local infection in the mouth, but a systemic inflammatory and autoimmune response throughout the body. So thinking further, how do we link periodontal disease as a possible risk factor for cognitive impairment? As I showed you before, we started with this cross-sectional analysis, and there has been a subsequent look at incident cases of dementia. And there's been a relatively consistent association between the number of teeth that people have in both midlife and late life and incident dementia, with the risk being somewhere between 30 and 50% increased risk for cognitive impairment or dementia. And a similar association was found for periodontal disease and incident dementia. So about a 20% increased risk for those who had periodontal disease and incident dementia. And it's also associated with AD mortality, and that came also out of the NHANES 3 cohort. Further explorations into periodontal disease and biomarkers of cognitive aging have relied upon large epidemiologic studies, both those in the United States and those elsewhere. And there are several recent publications that I'll point you to here, which did identify an association between periodontal disease and cortical volume loss, as well as another looking at white matter hyperintensities and diffusion tensor imaging, and the ERIC study, which, however, was a negative study and did not find associations. It also had a small cohort of amyloid imaging, and there was no association there either. So there's a mixed picture when it comes to biomarkers, perhaps, but a relatively consistent clinical picture. This summary I put together some years ago when I was first embarking on this, and it's evolved, thankfully, over time. But these highlight, I think, a lot of the issues that we're going to be talking about in the breakout session, and that we were largely limited to cross-sectional association studies. We've begun to develop some longitudinal epidemiologic data through our program and others. But when I first started looking at this, there were really no studies that had been a priori established to identify periodontal exposures and cognitive outcomes. We were really relying on add-on studies to adding on things about general oral health. And this led to an inconsistent linkage with cognitive outcomes, MRI, or other biomarkers of potential interest. So again, the main thing that we have to be mindful of in any study that we're looking at is the possibility of reverse causality. That is, as cognitive decline had been there already for some time and just led to inattention to preventative care, which is not nearly as interesting as the reverse direction that we're thinking about. So a bit more about the Washington Heights Inwood Columbia Aging Project. This is a multi-ethnic longitudinal perspective study of cognitive aging of elderly individuals, all residing in northern Manhattan and the southwestern Bronx of New York City. It's been going on since 1991, and there have been 3 waves of about 2,000 individuals that have been enrolled over time, with the most recent wave being roughly 2010. At each visit, medical, social, and health behavior histories are taken, and general medical examinations take place, and neuropsychological testing is also done. Increasingly, there have been measures of plasma biomarkers and MRI that have been done on many and even most of the individuals at this point. So our YCAP oral health study, the ancillary study of oral health, began back in 2013 thanks to funding from the NIDCR. And we included oral health questionnaires, tooth counts for all individuals, full mouth periodontal examinations, including 6 sites per tooth. We assessed for plaque, bleeding and probing depth and attachment level, and took 4 subgingival plaque samples per person, pursuing this through, at the time, checkerboard DNA analyses, as well as a pooled sample that was analyzed through the Forsyth Institute using their Homings analysis. And we did subsequent analyses in our microbiome center here at Columbia. We additionally took a select number of antibodies and explored for periodontal microbiota and serum IgG, as was done before. And overall, we enrolled about 1,130 individuals, most of whom were cognitively normal, with about 20% having some degree of cognitive impairment, and all of whom had some degree of cognitive assessment, or periodontal assessment rather, including subjective assessments, and those who could participate in periodontal examinations did. We had antibodies assessed and additionally microbiome analyses too. And the overview here we've published before back in 2018, and a few key things to point you to is that really at every age category, we found that over 75% or just about of our participants had moderate to severe periodontal disease. Not just a small little pocket here and there, but really a bona fide periodontal disease. It was quite prominent. We also saw that the average tooth count went down and that people became more edentulous with aging too. We also looked at different risk factors as far as sociodemographics, and it bore out some of the similar findings that have been identified before, including associations between increasing age, male gender, minority populations, lower education, and other medical risk factors. We took a step further and looked at the cross-sectional associations between the oral microbiome, and like others, we found a distinctly different microbiome between those with mild, moderate, and severe periodontal disease, and we looked at things in a different way, looking at quartiles of disease severity as well. Microbiome analyses are not simple, and those of you who are on the call who will be presenting later can attest that these really rely upon some very thoughtful analyses to think about various abundances and complexities of the microbiome. And this graphic here is all to say that there are differences that we can see, although they're not readily obvious. You can see that there's some separation between the microbiome based upon these quartiles and CDC AAP classifications too. We also last year published on the genetics of periodontal disease and the periodontal microbiome, aiming to validate some other groups that had looked at the genetics of periodontal disease, as well as explore for novel ones within our group. Interestingly, we did find some associations between the genetics of periodontal disease and some other neurological factors or relative risk factors for periodontal disease, for cognitive impairment, including platelet aggregation, coronary disease, and even one indicator for plasma tau. So, there are definitely associations here that we're seeing not just at the microbiome or clinical level, but even at the genetic level, suggesting this is a very multifactorial interrelated association here. Right now, we have some analyses that we're trying to bring to the finish line, focus on cognitive aging outcomes. We have some MRI volumetric changes that we'll be publishing on very soon. We're embarking on some longitudinal cognitive performance assessments. And with the infrastructure that's available through the YCAP study, thanks to our chair, Dr. Richard Mayu, we have the capacity of linking these to plasma biomarkers, which have been collected over the years. We're also interested in identifying some of the more direct pathobiological mechanisms between periodontal disease and maybe some of these associations, including whether or not diet is actually determined by oral health and not necessarily health choices, as well as understanding what access to care issues we may be facing, as well as awareness of oral health. How can we better understand how to educate people and get them access to care? So far in this multi-ethnic cohort of elderly individuals, we found that periodontitis is a very common condition. It is a health disparity. There's a complex immune host response. There are various measures of periodontitis associated with neuroimaging evidence of Alzheimer's disease-related changes, both cross-sectionally and potentially longitudinally. And there's incident cognitive decline or poor longitudinal cognitive performance that's been identified study after study. The relevance, I think it's also important to think back, how can we potentially link this to the framework that we have, the functioning framework that we have for Alzheimer's disease? Is it possible that amyloid, which is one of the earlier markers that we identify in Alzheimer's disease, which we know is a non-specific response indicator to various causes of brain injury, as well as brain infection, could that be an early indicator of reflection of Alzheimer's disease? in reflection of periodontal disease, and that the tooth loss and attachment level are evidence of that exposure across the lifetime, whereas the inflammatory or neurodegenerative phase of things, maybe that's related to oral inflammatory changes, and that's something we hope to look at with peripheral monocyte profiles and clinical neurological disease as well. So again, we have an ongoing study that's an R01 funded by the NIA, and we aim to reassess as many of those individuals as possible who we saw back in 2013 to 2016. To date, we've finished about 250 repeat examinations. And again, happening right now, we have tooth counts, whole mouth periodontal examinations, clinical dental imaging, including panoramic images, home visits. We also assess for the periodontal microbiome with 4 sites as well as combined. We do also take a salivary microbiome assessment, and we're anticipating looking at these on a metagenomic scale as well. And again, we have the, good, really by design, our good fortune of being able to link this with the infrastructure, which includes longitudinal neuropsychological testing, MRI, and the capacity of looking at ATM biomarkers through serial plasma assessments. And there are additional opportunities for looking at genetic replication, including consortium studies that are being proposed in Europe, as well as an offspring study that's part of the YCAP study, thinking about maybe there's a family microbiome to consider as well. As we will see tomorrow, we're going to have our breakout sessions. The questions were already posed. And this was actually something that Dr. Papapanou and I just wrote about in the Journal of Alzheimer's Disease in an invited commentary, in that there are many challenges that we face in our field. There's a challenge of timeline, resources. We want the answer now for something that takes a long time to understand. But it may be possible as an alternative, and to the extent possible, to characterize a large subgroup within established cohorts, enabling longitudinal assessments of exposures and outcomes of interest in aging and age-ed populations. But we have to make sure that we have the capacity for looking at things in a comprehensive, objective level, looking at the oral periodontal characterization through clinical, radiographic, microbiological, genetic, and serological associations, anticipating that there may be evolving definitions of disease, and banking specimens whenever possible, again, anticipating multi-omic approaches for understanding these relationships. We also need to assure that neurological biomarkers are equally complex and available in the majority of study participants and not just a select few. So the key concepts to think about in advance of tomorrow's breakout sessions: what did you hear from me and potentially others about the strengths of the evidence between oral health and Alzheimer's disease, as this may inform public health assessments and care going forward and prioritize research that we have before us? How can we optimize available research infrastructure and emerging real-world data programs that are coming together through the NIA and others? How can we identify additional approaches and methods to advance the field as quickly as possible, and ultimately identify concrete, immediate, and available collaborative opportunities to ultimately improve the health of many? I want to thank many of my colleagues, several of whom are on the call today, especially Dr. Papapanou, who's the chair of the section of Oral Diagnostic and Rehab Sciences here in the College of Dental Medicine, and my colleague, Dr. Ankatrin Uleman, who runs the Microbiome Center. As I shared with our group before we had when we had our planning session last week, I come from a family of dentists, and I also want to acknowledge that my dad, who's a retired periodontist, is also on the call here. So thank you, everybody, and thanks for having me.
Thank you so much, Dr. Noble. It is very interesting, and it's a really good introduction for our today's workshop. And I want to pass the floor to Dr. Brenna D'Souza. Thank you so much for joining, and we will do the Q&A afterwards. Thank you.
Dr. D'Souza, you're muted.
So good morning, everyone. My humble apologies for not appearing like I was on time. It was actually a problem with the link that I simply didn't have available in my invite, but we solved the problem. So I thank you, Dr. Noble, Jim, for your wonderful introduction. I think you have you're so aligned with NIDCR's own vision and NIH's own commitment to aging and ageism and the research that we need to do as we maintain much longer now. Longevity is very much part of our society. So thank you very much for the work you're doing. I bring many, many greetings from NIDCR and hope that in the next few minutes I can, oh, why are my slides not working? Oh, geez. Just give you a broad, paint the big picture view and to give you a little sense of the history of our institute, which was founded really on a public health concern rising at that time in 1948, when President Harry Truman was really concerned about the young men who failed to be enlisted in the war because they had bad oral health. And that really was, at that time, it was dental caries. It was about the time when fluoride, soon later actually was introduced into water fluoridation. So you can see him here actually signing in with Trendy Dean, our first director of this new institute called the National Institute of Dental Research. We changed the name when we hit the 50th year mark. But today we stay very true to that fundamental mission, which is to really transform human lives, and I mean lifespan long, through our scientific discoveries, to really improve health and well-being for all. And that theme, I hope, will resonate throughout my talk. So NIDCR is the third oldest of institutes on NIH's campus in Bethesda, and we own biological systems that I think are paradigms for organogenesis. Very proud of them. We have systems within this complex we call the dental, oral, and craniofacial complex that offer paradigms and models for organogenesis, for tissue regeneration, for inflammation, for immunity, whether it is teeth themselves that are patterned so beautifully and have the highest or the strongest tissue and mammalian systems, the enamel, that can't be replaced, or we have the tongue with its receptors, or the salivary glands producing a very unique fluid. And this really unique periodontal complex that is so, the ecosystem of which is really challenging to treat when inflammation and disease hits, right? So we have a variety of systems that we own and we're very proud of. Now, you can see here, the oral cavity is also the portal of entry for many of the common risk factors that predispose one to systemic diseases, as cardiovascular, metabolic syndrome, and many diseases are manifested in the oral cavity. It's also a means by which we can monitor healing and the effects of therapies on systems. We know that the face itself and that the structures within this complex actually are very important for defining who we are in society, and that there are inconsistencies and differentialities that really affect the health and well-being of our citizens. Now, it was in 2000 that the Surgeon General at that time, Dr. David Satcher, brought the importance of oral health to a national platform of awareness and recognition. And he tasked a team, it was under Hal Slavkin's directorship, to really look at the status of oral health in our nation. And you can see from the recommendations, or the key imperatives, that many of which actually hold true today. Interestingly enough, it was Surgeon General Jerome Adams in 2019-20, who, as an anesthesiologist who was looking into the mouths of individuals on a surgical table, saw what was in their mouths and was alerted to the fact that oral health was not really experienced by all in this country. And he charged NIDCR and a group of contributors, CDC, and the Office of the Surgeon General, to actually reevaluate the oral health status of our nation. It so happened, it was at the same time when COVID, the pandemic, was at its height, and the border crisis was emerging, mental health was an issue, and the report was transferred on, the responsibility was transferred on to NIDCR and NIH to champion through completion. It was a challenge because it was, in fact, the pandemic, but we had wonderfully committed contributors and leaders who made this happen. And this was truly a report that was a reflection of the facts of what's happening in this country. It was very data-driven. It followed a lifespan course. So we looked at every stage from infancy to aging adults to look at what the challenges were. And obviously such a document provides a roadmap for everything that we at NIDCR should be concerned about. The document itself is about 25 pages long in terms of its executive summary, and the report is about 790 pages. It's available online. It's electronically fully downloadable and well disseminated. So articles in the Lancet address, and I'll talk about this a little further, very specifically. This is not a US-based issue alone, that oral health, in fact, is experienced differently in different parts of the world, especially in, yes, less developed countries. We also specified in the New England Journal of Medicine that science will drive a lot of the evidence that we need for policy reform that we particularly need in this country. And then there were other articles that you can see that are targeting different stakeholder groups with varying interests, whether it's clinicians or educators, public health dentists, and of course, researchers who care about, like you, who care about this issue. And it was well disseminated. Now, if we looked at the last 20 years, we all can admit, and even more so with the pandemic, that times have changed. The landscape is rapidly evolving. Our demographics in this nation, the fact that we're going into a very digitized era where AI and machine learning can afford advantages to all the scientific questions we ask, that the delivery of services and our deliverables have changed as the public becomes far more aware of the importance of health. We see disease trends actually emerging that we would not have predicted. And one example would be HPV positive oropharyngeal cancers actually superseding that of cervical cancers in our nation. That's a little scary, despite the fact that the vaccines are effective. Young male adults are actually showing higher risks and disease, HPV positive oropharyngeal cancers than females. So the whole issue of should we revaccinate this population comes up. The divides and barriers in our society continue to exist, as do and almost paralleling our understanding of the importance of upstream health determinants that are socioeconomic, commercial, etc. Of course, the pandemic taught us many lessons. But so we have all of that. And then we have a report that says, hey, have we used everything we know and translated into what we actually do? And that is, I think, the driving question that we must apply to the field of aging, gerosciences, as we look at a population who have deserved the right to have full health benefits and take advantage of all that science and technology bring. So these are our statistics you can see very clearly delineated and what the report actually highlighted. Now, very magically, at the same time, the World Health Organization had mobilized a group of scientists and public health dentists to bring to attention the fact that oral health is extremely critical for general health and well-being. They passed a resolution asking for oral health care to be included in a universal health care package. And for a good reason, because if you looked at the statistics globally, you can see that it's still a huge problem, costing us about 500 billion in terms of burden, of economic burden. And this covers both the infectious diseases, cancers, etc., and gender-based as well. So the Lancet Commission specified that, and they did this with a huge commitment. They came up with a special issue in 2019, I believe, that focused on the inequities that exist. Now, we know that when we talk inequities, health inequities, it includes just every age group. There's no one who's exempt from that if, in fact, you have no access to care and can't afford quality and safe care. What I thought was probably the most significant of the statements made by Francis Collins and Vivek Murthy in this co-authored article was to state that people in the US experience oral health differently, and that it's its importance in terms of being vital to the health and well-being of individuals has not been and is not equitably addressed available across the US. So a little more on the report, as I mentioned, 400 plus contributors organized across the lifespan. Now you can tell that there was a very concerted effort to focus a section 3B, on older adults. And this, as for most of you that will interested obviously in this topic, please do read that section. It has a lot of detail and data actually of relevance to what you do. And you can see from this cloud diagram that there are conditions that leap out at you that affect the status of oral health in these individuals. The challenges identified by this report is that quite a large percentage of adults 65 and older have no coverage, have no dental insurance. And when you move, actually, I have data that shows this from private to, say, a Medicare policy, that dip in the quality and access to care actually declines. And you can see that that is a major barrier to dental care and obviously the costs associated with it. Disparities persist for race and ethnic groups, and there was solid data to prove that, and 2 more slides to follow. And that the impact of systemic conditions and medications on oral health can no longer be ignored. The oral cavity is connected to the rest of the body. And you will see that in the oral cavity, as you age with multiple medications, likely to suffer from decreased salivary flow and hypofunction, that then predisposes individuals to higher rates of dental decay. So root caries that appears in aging adults is actually a common feature. And of course, periodontal disease as associated because of systemic complications rises in this group of individuals. And you can see here from this that the percentage of adults who are over 65 with periodontitis, if you looked at the difference between men and women, not remarkable, but certainly women are less predisposed to periodontitis. Now, focusing on this infectious disease that individuals like George and Panos are really working hard to explore and to expose. In non-Hispanic whites and non-Hispanic Blacks, you can see the difference that non-Hispanic Blacks are showing almost an 80% incidence of periodontitis. And as you go on, you can see that smokers are actually much more predisposed to this disease trend. We also looked at, the group also looked at complete permanent dentition, what is being retained in individuals who are aging. And you can see again that socioeconomic factors, that race and ethnic backgrounds actually influence the incidence of tooth loss and or preservation of natural dentition. And that's an important fact to remember because there is emerging data to show that edentulism, as in literally having no teeth, is really directly associated with cognitive decline. And individuals that have dentures put in, not implants necessarily, because implants are a difficult mode of treatment when in fact the bony ridges are so resolved and knife edge. It's almost better at a certain age to be thinking of dentures. When you have an individual who's in his 70s or 80s with dentures, it actually does affect nutrition, diet, speech, appearance, social connections, etc. So I think the report emphasized, and this is picked out from a new article that Jane Weintraub is has just submitted, and it's reiterating the same theme that we can look at a given population of aged individuals in a microscopic reductionist way, that we have to look at the circumstances this individual is faced with, home care versus care in a facility, economics, health, and nutrition. All of these factors at the individual, household, and community level influence really the health status of individuals. As we all look at it as younger today, we will all face these threats eventually. Now, it so happened that at the time the report was on, and I came on board as a director, one of my responsibilities was to champion and to spearhead a new strategic plan for the Institute. And it was made complete sense to be looking at what we should be doing in light of the pandemic. So we had to approach this with a new set of lenses and almost in an agnostic way. So there was no disease preference or any particular organ system that for me was my favorite. I do have some, but I put that secondary. I focused on the big picture, the need for us in science and technology era, in this golden era of science and technology advances, to be able to take what we know and translate it to what we do for the benefit of our patients. We can't be completely productive if we are not including individuals who represent the demographics of our nation. And then, of course, measuring what we do is very much part of NIDCR's culture today, as it is for NIH. And you can see the core values of what you would predict would be important. And we're doing this with an emphasis on aging in many ways. So the first goal, which is to put the meat on the bones of oral systemic connections. We've had a lot of associations in the past. And now we're beginning to see new evidence, molecular evidence or mechanistic evidence connecting what happens in the mouth to what happens in the rest of the body and vice versa, whether it's the oral gut microbiome, whether it's systemic manifestations of oral diseases and vice versa. We are actually advancing on that front with the goal that we can go on to goal 2, which is to apply individual methods or techniques or approaches for managing individuals. And that is true for the aging population as well. That we need to really invest in implementation sciences, an area that is less developed, as relatively speaking, nurturing a diverse future generation and expanding on partnerships with institutes like the National Institutes of Aging that we are very thrilled to be collaborating with on different levels. And I wanted to point out on the left this important schematic that NCATS developed, because what it does is it doesn't create the linear continuum of basic science or foundational sciences on one end and clinical applications on another. It actually connects us through a circular continuum where every component is connected with one common mission, which is to benefit patients. So the patient is in the center, and you can see that everything we do in this field of research must utilize all these domains of science. And NIDCR remains committed here to aging research because we are looking at, from a disease perspective, from early prevention to management to cross-cutting approaches. And you can see the disciplines include aging research, and our portfolio will continue to grow in this area over the next few years. So I'm going to give you a few examples extending from all that Dr. Noble presented of what I consider the key findings from the investments that we've made. One that comes to mind right away is that there is a connection between periodontitis, and I think this is George's work, or is it? I'm not sure, sorry, that in an experimentally induced system of periodontitis, and you can do that actually creates a systemic response within the bone marrow where myelopoiesis is occurring, which is the development of the major blood cell types. And that, in fact, in circulation can exacerbate conditions that are present elsewhere in the body. And this was proven here with interleukin-1 being the chief modulator. So this maladaptive immune trained myelopoiesis actually plays a role in the comorbidity connections between periodontal disease and, in this case, arthritis. Very interestingly, an early stage investigator is studying now actually in clinical trial the response of the effect of rapamycin, known to be an anti-aging drug, also used for cancers, and showing that in fact it is possible to treat gum disease through rapamycin, and that when you do that, it actually decreases the amount of bone loss in individuals who are taking rapamycin. And you can see that here clearly represented here. Of course, these studies are in trial, so it'll be very interesting to see if one can attenuate periodontal, which is definitely a disease, periodontal disease, a disease of aging, the aging process. Or we could call it a natural process, but it is actually an infectious process. In this one, clearly I can't see my own slides. We looked at this group studied the effects of or the conditions of microbiota or the microbiome in women who were experiencing postmenopausal effects. And so, of course, in this osteoperio study, there's a clear connection between subgingival microbiota and hormone therapy. Significant differences being noted between postmenopausal women who have either taken or not taken hormone treatment, and you can see that clearly. So there is, again, another indirect way here of showing that there is a connection between what's floating in our systems and what's actually happening in the oral cavity. Interesting enough, if you develop prediction models to actually identify and predict in advance which individual is going to actually suffer from a cognitive decline and other effects of aging, you can do that through looking at edentulous states versus those that are dentulous, partially or fully. And you can see that that was predicted of this prediction model could actually go beyond what we consider the normal risk factors of smoking and oral health care, that you could actually predict about 12 years in advance of who would be subject to cognitive decline. The Alzheimer's pathogenesis connection with periodontal disease and this is one of a couple of other studies that shows that this bacteria, Fusobacterium nucleatum, present in periodontal pockets, can cause inflammation and neurotoxicity that affects the deposition of tau fibers and amyloid deposits in the brain of these mice. And I thought that was very interesting, is to connect that. Now, the translation to human studies would be very important for this particular pathogen. The National Institutes of Health also funds a program in oral health research. And I wanted to mention that, in fact, there is a UO1 now. The deadline, it's probably in review, this particular grant. And Preeti Chander is the scientific contact for this UO1. And the main objective is to actually focus on immunity in older adults and to gain a much better understanding, a much more detailed understanding of the immunologic processes that seem to parallel the aging process in humans. And the focus being obviously on dental, oral, and craniofacial health and pathologies. Very interesting that tooth loss in older adults is associated with a higher risk of cognitive impairment and 28% higher risk of dementia. So, and it was interesting that the number of teeth loss, obviously the function is related to the number of teeth. If you have more, you can chew better. And you know, the direct links are not yet proven, but you can imagine that if you don't have teeth and you're not chewing correctly, your diet is compromised, your social skills and your wanting to withdraw is very natural, right? When you have to hide your mouth and be aware of your condition. And I thought the interesting part of the study was, as I alluded to before, was that if you treat these individuals with dentures, that you do see a slower rate of cognitive decline. And it's as related to tooth loss. It might be secondary, but it is a valid connection. Finally, NIA study on gum disease associated with Alzheimer's, and I bet you Dr. Noble's work is in this important study, and it's looking at NHANES data and connecting age or lifespan aspects of 65 years and older populations to Alzheimer's diagnosis and deaths, especially associated with another organism, P. gingivalis, which is very much the prime pathogen for periodontal disease. So clearly, we will continue to invest on whether treating P. gingivalis infections can actually mitigate the symptoms of dementia and cognitive decline. Now, if you looked at NIA's investment in understanding that link, it's real, and it's identifying the antibodies for at least, so they've taken a very broad approach of looking at a huge array, 19 periodontal microorganisms, and to see and to assess levels of these bacteria in, it could be gingival fluid or saliva, that are included or involved in cognitive decline. And you can see that several antibody clusters are in fact associated with these organisms right here. These organisms are associated with cognitive impairment. So one can conclude here that gum disease may in fact be a valid predictor of cognition or the level of cognition among older individuals. That this study was actually done in the UK and in the US, where they looked at oral health being really important for overall health here, and being, individuals who can use their muscles, who engage in physical activity, are most likely those who have optimum oral health, and those that don't actually obviously show poor diet quality, overall decline in health, and this is related to what you actually take in as nutrition. An important population science study. As I mentioned before, the transition to Medicare does come with compromises for the elderly. And you can see here from this panel survey that restorative dental care visits declined by almost 9%, and that complete indenturism, or the loss of all teeth, increased for those at age 65. And those who are enrolled in Medicare Advantage, that program showed far greater use of dental services than traditional Medicare enrollees. And I know that Natalia Chalmers is on here and is doing excellent work in CMS to look at ways in which we can include oral health care for those individuals who have medically compromised conditions. And I'm hoping that that continues to grow such that oral health care is seen as a really basic element for overall healthcare or general healthcare. I want to end here with two diagrams that are soon to be published, and this is with permission from Dr. Weintraub, that as we forge ahead in areas of aging research or geroscience, that we keep in mind the complexity of the biological systems we're dealing with. And for oral, dental, and craniofacial tissues, they really truly are unique and challenging as well. But they are in fact important indicators with connections to the aging process, to the overall biology and health well-being of individuals. And you can see here listed are those scientific domains that we must approach in a multi-pronged fashion, almost a holistic way of integrating across our systems. Again, the emphasis on the upstream determinants of health apply to the aged population more so than any other. I feel that they, along with infants, are the most vulnerable of our society. That we include in our studies these parameters to evaluate conditions and circumstances that really influence cognitive health and overall well-being for individuals in this group. As you can see, the connection between that and aging is strong. And more than anything else, for those of us who are educators, I was an academic for almost 40 years, know that the whole field of gerosciences is not very well represented in our educational systems, and whether it's medicine or dentistry or any other one, nursing and public health. And for NIDCR, we embrace these domains because we are one, in fact, maybe with nursing, the only institutes that have the responsibility to safeguard a profession. We derive our clinical scientists from dental schools. And so for us, communicating to clinicians and to the educational sector is very important. The importance of this arena of science, the commitment that NIDCR has made, especially to training the next generation of aging or oral health researchers, is critical. I want to end here by saying that the strategic plan emerged independently, but is very aligned with this important Oral Health in America report that provides the imperatives for the future. They're both linked, and I think for us at NIDCR, along with our partners in the National Institutes of Aging, will work to making this a reality such that we meet our strategic goals, paying attention to the public health crises that we face in many areas of oral health, and so that in the end, the outcome would be oral health for all. And that is the all is emphasized here. So I want to thank you and ask you to join us in celebrating our 75 years. We have a host of activities planned for the year and open to any questions that you might have. I appreciate being invited here and the opportunity to connect with this very specialized group of researchers. Thank you very much.
Thank you so much, Dr. D'Souza. It is a pleasure having you, and it's really nice to see the intersection and collaboration within medical providers and dentists, which is really hard to see sometimes, and the synergy that we are seeing today. So I invite everybody to either post their questions or raise your hand if you have any. And I want to invite everyone also to take a look at the document for Oral Health in America, Advances and Challenges. It's a very lengthy document that it can be overwhelming, but we have snapshots and summaries that you can take a look based on the topic of your interest. I was fortunate to be one of the collaborators, so I know what it took for all of us to put that together, and it has a lot of information that we can learn about the challenges, the social determinants of health, and so on. But I want to take the time today to answer some questions if the public or the audience have any for today.
Stephanie, would you allow me to acknowledge Dr. Hodis Richard here, because I didn't see you in the panel. Richard, thank you for being so open and welcoming for me personally, as a new director, relatively speaking, but also for your amazing leadership of the National Institute of Aging. I thank you. It's a thrill to be a colleague.
Hey, well, a pleasure and treat to be here on the screen and the meeting with you, Rena.
Thank you.
So while people are thinking about some questions they might have, I would like to invite Dr. D'Souza to tell us perhaps a little more about the initiatives from NIDCR. We have a mix of dentists that we know what NIDCR is doing right now, but as a former fellow from NIDCR and like young investigator, I have been having challenges on finding data or collaborations. So if you can tell us a little more what we can do as a profession, not just as dental and medical providers, but as a profession in the healthcare field, how we can all work together and merge the forces to actually do more for our aging population, which is around the corner.
Thank you. It's a very, very good question. And of course, Dr. Noble can answer it as well as I do. And we have certain symbols of our time, right? And today I feel, being at NIH, that the theme that is emerging that can't be ignored is the need for integration across our ecosystems. Cross-cutting themes, looking at holistic care means that we talk to each other across the boundaries that separate us naturally, that we come together to realize common goals, which is always the patient in the center. And I think you'll see a series of initiatives that are coming from NIH in the last few years, whether it's ARPA-H being very focused on fast-track, patient-centered, use-friendly research, to collaborations between institutes that have in the past focused on their own missions. And we can see it all coming together in many, many programs, too many to list actually. And so I think as a researcher coming in, being aware of this, where the leading edge is going, making sure that you know who your program officer is to contact at NIDCR or the National Institutes of Aging or any other institute at NIH is very key to know, so they know who you are, they know your interest area, and can help you position for funding. If you are in fact an early stage investigator, which is another priority for NIH, is to invest in early stage investigators or first time investigators. So I have many examples of the opportunities now. The RFAs, the NOCs, the NOFOs are all out and very well delineated on our website. So do access that, Stephanie.
Thank you so much. And Dr. Noble, thank you so much for all what you're doing to integrate oral health. You're very unique because you had the background from your dad, which I want to congratulate early for Father's Day. We have a question for you. Given the insurance and access challenges, do you project refer or facilitate dental care for participants in your cohort? And if so, how is that built into the design of your longitudinal study?
That's a great question. I'm happy to answer it. We've actually offered emergent and urgent care referrals for all persons that we evaluate in the study since its initial wave. We have actually, at least on a surface level, I'd say, detected a greater degree of access to care issues coming out of the pandemic. So I think it's important to kind of frame the timeline of when we've been doing our more recent wave, which is basically 10 years after our initial enrollments, we're now seeing persons back for the second time. These are all individuals who were 10 years older, and at their youngest, they were 65, 66 when we met them. So they're now at youngest 75, 76 now, aging into their 90s. These are individuals who are less mobile, less, and facing more progressive problems with oral health. We began enrolling people right at the kind of tail end of the, well, not even the tail end. We're still in, I think, the tail end of the pandemic, but in 2022, just over a year ago is when we first started seeing these people again. And that was a time where a lot of things have been put on the back burner for a while. And I think oral health definitely comes to mind for that. But the big challenge we've been facing is, even though we have a dedicated dentist who knows these people well, we have a coordinator staff, we even have a social worker as part of the primary study to help make sure that people get care. One of the fundamental barriers we have is that even when there's a problem that's identified, who's going to pay for it? These individuals don't have dental insurance, or they have very limited dental insurance, and they're only going to pay for what is absolutely urgently necessary in that moment. We do have some capacity for covering some of those costs, but for a lot of the preventative measures that would probably serve them in the long run, there's just no real central mechanism for it. Yeah. And so I think a key point that Dr. D'Souza brought up, and one that really needs to be part of not just NIH discussions, but thinking about this and even for CMS, is can we think about having some sort of broader coverage when it comes to universal dental care coverage for those who are in aging, because those are also persons who are especially financially vulnerable, where if they have to pay for two things, it's going to be a bill before it's going to be their teeth. So these are things that are beyond the scope of our work, but I think what we've detected in the community is that this is a key issue that needs to be addressed for sure.
Very well, Stephen.
By any chance, this is a question of mine, are you including any educational component for them to take care of themselves better once they know more, like oral health literacy, for example?
Yeah, all persons that are seen in our study are given toothbrushes and dental floss and toothpastes, and they're given just general tips on oral hygiene chronically. We're not really in a position to see them longitudinally. We see them really once as part of the assessment 10 years ago, and then once more recently. In our research group, Dr. Papapanu and I have a research hygienist who's actually been very involved with various educational initiatives, and increasingly we've been relying upon her to help us work with this study, and we anticipate working with her further to think about how can we improve some of these awareness, access, and issues that become really chronic barriers to care. It's an important point for sure.
I have a question that is for the two of you, so you can take your dive and answer each separately. How can the profession of dental hygiene add to the body of research in neuroscience and be value for the discipline in preventive oral health?
The second part of that question is really reflective of the hierarchical nature of the oral health profession. So you know that will take a lot of a culture change, perhaps in ADA's own thinking. Clearly, the role of the hygienist is that of the watchdog. They're the ones who spend time literally looking in the mouth as they scale or clean every tooth, aware of the oral mucosa. They do head and neck exams, very much part of that team, very much part of the educational team for patients. I can stress more the value of, and NIDCR is really thinking, because of the need from the Dental Hygiene Association, the American Dental, to invest in a PhD level training for dental hygienists. I believe, just like physician assistants, that their role as serving as watchdogs, being observant and translating that into new knowledge is important, and it might take that investment to develop a scholarly pipeline or pathway for dental hygienists. So that's what we're doing. And I'm sure Jim has more to add.
Yeah, I would add that this doesn't end with neurologists or periodontists or hygienists, but actually we can think about other pools of individuals in allied health, including non-conventional ones. Two projects that I work on outside of the realm of oral health, but I think ultimately can be connected, involve a community health worker program where we've educated close to 150 community members, all of whom are senior members in local churches and related organizations in the community. And we know that there are countless examples of how community health workers, when effectively trained, can really be multipliers of efforts that are being done by many. For all the efforts that we have in investments into professionals being trained, the reality of it is that even if you started investing now, you're waiting 7 to 15 years before you're going to have really a qualified workforce. And even then, you maybe will have a 20 to 50% growth. You need multipliers of these individuals, not a fractional increase. The other component is to think about what other educational initiatives that work that we may think about adapting as well. As I said, one of the other things that I do is community health outreach and education programs where we actually teach elementary school aged kids about various health initiatives. The first one we did was called Hip Hop Stroke. We're just finishing up a randomized trial called Old School Hip Hop, where we're teaching 4th and 5th graders about dementia, with the aim being that they take that information home and get their parents just as excited about buying toys, this time getting excited about things like oral health. We use multimedia outreach strategies, cartoons, songs. Our programs were in schools just this morning teaching 4th and 5th graders about dementia. And this is the way that we can think about, if we identify a way to really get people engaged in oral health, to get engaged in, really taking some measures towards improving their oral health and improving the family's oral health, making them realize that it's important and making them realize that there's a mechanism for getting that support. Because if at the end of the day, there's no way to pay for it, then you've still got a barrier to care. But it begins with education as a first linkage towards getting people into care, because as much as we've talked about health disparities, once people hit our office, the bigger issue that we continue to see out in our community is that people are just either averse to care or unaware of their problem in the first place, and that ultimately delays the diagnosis. There is no exception to the rule that earlier detection and treatment makes a difference, and that begins with identifying things across the life course and making people realize that these things are important and should take time to do it if they have the resources to take care of it.
I just want to add one more thing as we continue the discussion for today and tomorrow. So another factor that is also preventing access to care is the shortage of dentists and hygienists working very closely, for example, in New Hampshire areas. People are really looking to hire, but there are nobody that are taking those jobs. So people are really struggling to find that appointment on time sometimes, especially in rural and remote areas. So as we're thinking and brainstorming, that is something that we really also have to think about, especially because geriatrics is not a dental recognized specialty. So that is going to create workforce issues or shortages in the future, in the near future.
Dr. Egan has a question.
Yeah, so
Oh,
I
yeah,
would-
thanks very much. Fantastic symposium. I'm so happy about this symposium. So I'm work in the National Institute on Aging. I'm the clinical director, and I have a specific interest in diabetes. I just want to say that 1 in 4 people, maybe more, over the age of 65 have diabetes.
Okay.
And the importance of oral health in diabetes absolutely cannot be overstated. We talk about exercise, we talk about nutrition, but oral health has to be right up there.
Yes.
Not only do I think it's so important for prevention of vascular disease, but also because of the tie-up between the diabetes, dementia, and oral health. You can put the 3 of them together and say, that's it. If we could just get after the preventable causes of dementia, which we do know, and oral health is so important up there, we could make a huge difference.
Absolutely. You know, Dr. Egan, your point is so well taken, and I didn't cover that topic very well. I'm sorry.
That's okay. It's
time
just something that's been a huge thing that I keep trying to drive home.
Yeah, but you know, it'd be really nice to hear from Natalia Chalmers, Dr. Chalmers, who is really heading the first oral health division at CMS, to see how one can implement to policy. At NIH, we cannot be advocating for that ourselves. We're not involved. We have to stay in our lane. And so that's already restricted, right? So I would love to hear from you, Natalia, as to what your division is doing about these systemic relationships and how one can engage AARP to be advocates for oral health amongst their membership itself would be very important.
Thank you for your questions and remarks. Do anybody has any additional questions that we can follow up at this moment?
Sorry.
Any additional recommendations that you might have, Dr. Noble, for your medical field to think more about oral health, as we really need that to move along sooner?
Well, I just want to highlight the fact that, you know, this work came together because of a longstanding collaboration between Dr. Papapano and I. We've been, you know, really, he's been a great mentor of mine now for over 15 years, and it's that kind of longstanding relationship that really, I think, has brought our work to where it is in a very kind of measured approach that we've taken, and really building upon the infrastructure that we have available here as part of other initiatives. I will also highlight that one of the training programs that we have in our center, the research education component as part of the Alzheimer's Disease Research Center, has the capacity for having transformative educational programs for persons from non-conventional backgrounds. And we actually supported one of our rec trainees, just completed 3 years of support. And as I mentioned before, she's a hygienist with an educational doctorate in outreach. And these are the kind of small scale initiatives that really need to be brought up to a larger degree if we're going to make some sort of meaningful impact. I think the other thing that comes to mind, and this is something that I've had some discussions with my program officer about, is we have very large training programs that are going on here at our center that are largely directed towards medical students becoming kind of transformative researchers and leaders in cognitive aging and related neuroscience initiatives. Yet there's a growing interest in dental students actually working with people like myself and Dr. Papapano, to the extent that we don't have the capacity for training all of these individuals. We would get 1 or 2 such requests on an ongoing basis, and we had close to 10 people just this spring wanting to work with us. There are no mechanisms that I'm aware of developing some sort of training initiative for such programs. And we'll also highlight that training initiatives in general are under-resourced for the individuals who run the training program. So if a new training program is going to come together, and I think this is something to bring back to the NIH, is that currently training programs do not have appropriate indirect cost recovery. There's no support for its PIs or its trainees or trainers. It's only support for the trainees. And so if we really want to, put our money where our mouth is when it comes to kind of developing these initiatives, we need to support educational programs at the same level that we support scientific programs. That's the only really way to get this multiplier underway, because there's no shortage of interest out there. It's really a shortage of resources to make it happen.
Absolutely. And I can tell you that trainee stipends are not that great either. That's, as you know, a central issue in this country today. What you bring to mind, Jim, is the need for us to also create targeted training programs in areas that need development, that would bring professional teams together across the great divides that separate medicine from dentistry and nursing and pharmacy. And that is a concept that some institutes might adopt, but it's definitely worthy of consideration. Because we're talking integration, we better be training people to think in that way.
Absolutely. We have interdisciplinary days here at our campus, but they're, it's a day that we all come together between allied health specialties, physical therapy, speech therapy, dental and medicine, and so forth. Right. And that it shouldn't just be one 365th of what we do. It should be every 100% of what we do if we're going to treat the totality of the patient. But again, I think it comes back to whatever we, those who are able to advocate for our patients on their behalf, if we can improve their access and support for chronic disease management, there are measures to support blood pressure medications and glasses and hearing aids now. Why isn't dental health on that list? What more do we need to prove? I think it should be a challenge to us. What more do we need to prove to say, not only is this a common problem? I mean, think about, is there any other disease that's out there where 75% of people have this disease and only a small fraction of those have the means to support its care? I don't know of another example like that out there. And I think that's a key part to start with.
Well, I have one up on you. I've known Panis for 30 years, I think. And I'm so grateful that he has collaborated with you and welcomed you into this team. And most grateful to your dad for raising such a responsible researcher. I can only see the tip of your head, David, but I know that it's a good one. There you are. There you are. You should be proud.
I just want to mention, I don't know if anybody from the audience is coming from the Health Resources and Services Administration. I know that they have training grants to develop or train people. I know that the geriatric dental program was removed or reduced at some point, but it will be very interesting to raise awareness about the importance to bring it back and to have the collaboration interprofessionally, because I know that it was medical, nurses, and dentistry at some point, and it was reduced, and we need to bring it back and to have more than one dentist train every year or 4 years. So that's not enough.
It's not a recognized dental specialty.
No.
My daughter's a psychiatrist and she specializes in geriatric medicine and practices that. So, but we don't have it in the oral health, and it's so needed. Absolutely.
Yeah, it might be interesting to look. I know in medicine, the interest in geriatrics has actually gone down. There was a study looking at 2000 versus 2018, and there was a 13% decline in the number of persons matching into geriatric medicine over that time. At a time where we're seeing, more and more people aging and facing more and more diseases of aging as well. I mean, the net effect that we have right now is that, some of the new therapies we have for cognitive aging, there just aren't enough of us to help manage them.
Yeah, probably related to reimbursements is what I'm thinking.
Yeah.
I don't think provider codes are matching up the needs of our population, sadly.
Well, thank you so much. And if there are no more questions at the moment, we can take a break, and I will give the floor to Miriam, just in case any logistics are needed right now.
Thank you so much. Thank you so much, Dr. Noble, Dr. D'Souza, and Dr. Chamut. Really wonderful presentations and great discussion. I would also like to thank Dr. David Noble for joining us. It's great having you here. So we're a bit ahead of our schedule, so we can actually take a little longer break. And we will see you back at 12:10 to start our session 1, the epidemiology of oral health and Alzheimer's disease and related dementias. Thank you all. See you back at 12:10.
Hi, Panas. Your office looks very neat. I'm worried.
Just for the occasion.
Oh, so good to see you. And thank you for working with Dr. Noble.
Pleasure.
Are there any presenters presenting this afternoon that would like to test sharing their slides?
I think I'm good. I hope I'm good.
No worries, Dr. Mansky.
Funny, in the middle of the presentation, I lost power.
Oh, wow.
So I had to go run up and I started a laptop, which will have power, and I could use a hotspot if need be. But
Okay, if need be, sir, I also have a copy of your slides.
yeah, but I've changed them several times since. I'm good. Well, let's just hope for continued power.
Yes, sir.
Right. It's 12:10 and we can get us started. Welcome back, everyone, and hope you all had a very nice break. We will now start our session on epidemiology of oral health and Alzheimer's disease, and Dr. Dallas Anderson and myself will be chairing this session. Dr. Anderson is a program director at the NIA Division of Neuroscience and a member of the planning committee for this workshop. I will now turn it over to Dr. Anderson to introduce our session speakers.
Thank you very much, Miriam. I have worked in neuroepidemiology literally for decades, but this is my first serious exposure to the linkage between oral health and neurodegenerative disease. Now I'll never be the same. I'll always wonder about the oral health of the subjects in those studies in my grant portfolio. In session 1, titled Epidemiology of Oral Health and Alzheimer's Disease, we have 3 speakers, Dr. Stephanie Chamut, Dr. Richard Mansky, and Dr. Bai Wu. Dr. Chamut has already been introduced. Let me go ahead and introduce Dr. Mansky and Dr. Wu. Dr. Mansky earned his DDS at Howard University, his MBA at the University of Massachusetts, and his PhD at the University of Maryland. Currently, he is professor and chair of dental public health at the University of Maryland School of Dentistry. As the chair of dental public health, he manages and provides oversight for a team of faculty and staff, educators, and researchers. He studies the effects on dental utilization patterns associated with changes in dental coverage and changes in retirement status among older Americans. Dr. Mansky also serves as a senior scholar at the Agency for Healthcare Research and Quality within the Department of Health and Human Services. As a senior scholar, he provides advice to agency staff into the editing and imputation of medical expenditure panel survey data related to use, source, expenditures, and health insurance benefits for oral health care. He also provides technical assistance and advice to the oral health community on issues related to dental policy, expenditures, dental benefit data, and dental utilization data. Dr. Bai Wu is the Vice Dean for Research and a Dean's Professor in Global Health at Rory Myers College of Nursing, New York University. She's currently leading several NIH-funded projects, including a clinical trial aimed at improving oral health for individuals with cognitive impairment. Additionally, she co-leads the NIH-NIMHD-funded Rutgers NYU Center for Asian Health Promotion and Equity, where she leads an intervention study that aims to enhance health outcomes for Chinese and Korean dementia caregivers. Dr. Wu serves as a principal investigator for the NIA-funded Asian Resource Center for Minority Aging, RICMAR. Her extensive publications cover a wide range of areas in aging and health, with a particular focus on dementia caregiving, geriatric oral health, and risk factors associated with cognitive impairment. In 2017, Dr. Wu received the Distinguished Scientist Award for Geriatric Oral Research from the International Association for Dental Research. Dr. Wu is a fellow of the Gerontological Society of America and the New York Academy of Medicine. Additionally, she's an honorary fellow of the American Academy of Nursing. So let's get started with our session. Dr. Shamut is the first speaker.
Thank you very much, Dr. Anderson. Can you see my screen well?
Yes,
Yes.
looks great.
Okay. Well, good afternoon, everyone, and thank you so much again for your interest in attending this workshop. Today, I would like to share some information on oral health, Alzheimer's disease and related dementias, aging, and principles for advancing health through an integrated practice. I am Dr. Stephanie Chamut, instructor in oral health policy and epidemiology at Harvard School of Dental Medicine. The primary goal of today's presentation is to provide a clear understanding of the epidemiological aspects of oral health and its potential association with Alzheimer's disease, to highlight the oral health impact in overall health, well-being, and quality of life, present epidemiological associations on the prevalence of poor oral health with Alzheimer's disease, and discuss risk, the pipeline for change, and the next steps. But first, I want to highlight a historical record. George Washington suffered from dental problems throughout his entire life, and he lost many of his teeth as a result of periodontal disease, tooth decay, and other dental issues. In fact, the scar on Washington's left cheek was the result of a bacterial infection caused by an abscessed tooth. This highlights the importance of preventive practices to reduce the risk of serious health complications. Acknowledging the population trends, we should all be aware that by 2035, the number of Americans aged 65 and older is projected to exceed the number of children under the age of 18. And this shift in demographics has significant implications for healthcare, social services, and the economy as a whole. Also, this means that the oral health disparities will widen. In addition, as I mentioned earlier, it is unfortunate that dentistry doesn't have yet a recognized geriatric dental specialty, which also create an inadequate geriatric dental workforce supplies that will pose a burden to meet the growing demands of older adults' oral health needs, especially among those in rural and remote areas. As individuals working in healthcare, we all need to become trailblazers in healthy aging and include oral health within our work. It doesn't matter what we're doing, but we have to include oral health. Oral and overall health are conjoined, and the mouth is part of the body and its entryway. However, since the early 1800s, the dental profession has been taught and practiced as a separate profession from medicine. As the number of precedent changes in the US population are happening and access to care challenges and the burdens of financial costs prevail, we need to think about how to adapt traditional and non-traditional models of practice and care to consider oral health and to improve sustainable healthcare delivery and positive health outcomes. So we cannot keep working in silos. Recent evidence also highlights the biological connections between oral diseases and neurodegeneration in older adults. And this is emphasizing the recognition of oral health as a fundamental aspect of overall health and well-being. Among older adults, there has been significant improvement in tooth retention over the past 20 years. More older adults are retaining most or all of their teeth, but this is also a great achievement, but it's also creating a higher risk for oral and systemic diseases. Dental caries, periodontal disease, and tooth loss are key indicators of oral health for older adults. The mouth is more than just teeth, and it is crucial to acknowledge that oral diseases are among the most prevalent diseases worldwide, where nearly 4 billion people are being affected. Worldwide, tooth decay, it is the most common non-communicable chronic disease, and severe periodontitis is the 6th most prevalent condition. Chronic oral diseases and poor oral health are mainly the result of inadequate or neglected oral care, as oral problems are often not sound until too severe. Oral bacteria is linked to numerous health complications. Systemic diseases like diabetes, cardiovascular, and Alzheimer's and related dementias, which affect approximately more than 6 million people just in the US and more than 55 million worldwide. Also, almost half of the world's population is impacted by untreated tooth decay and poor oral health, and this is due to oral health neglect, lack of oral health literacy, high cost of dental treatment, inadequate access to dental care, which is also increasing the risk of oral health problems. And at times, it is exacerbated by other medical conditions or their treatment. About 90% of all systemic diseases have oral manifestations and affect the quality of life and place remarkable emotional and financial burdens on individuals, families, caregivers due to pain, functional limitations, disability, and dependency. Not addressing the mouth-body connection has fueled the non-communicable chronic diseases crisis, killing about 17 million people prematurely each year, and it can cost the global economy 47 trillion by 2030. Without prevention or early detection, all diseases become more difficult and more expensive to manage, from all the considerable need for long-term care and all the treatments. Oral health problems and food ulcers are two very different health issues that can have significant impact in individuals' health. They differ in terms of their nature, their causes, their consequences, but despite their differences, both can have detrimental health complications that and shall be given equal importance. Both require timely attention, prevention, appropriate healthcare interventions, and this is just to minimize their impact on the individual's overall health and well-being. Good oral health supports individuals in many aspects of life. Dental problems can affect an individual's ability to chew properly, and this can lead to difficulty in consuming nutritious foods or to rely on more carbohydrates, which are not often the ideal for many. And this can result in inadequate intake of essential nutrients, which can negatively affect overall health, well-being, and systemic health. Also, pain and discomfort can cause difficulty to eat, speak, and perform daily activities comfortably. And this can lead to reduced quality of life, communication, socialization, and much more. We need to keep in mind at all times that nearly all dental diseases are highly preventable when people receive the right support and knowledge to prevent them. Policies, health information, research, and access to care are pivotal, and they work hand in hand. When it comes to addressing the needs of older adults, it is important to consider both equality and equity. While older adults should be treated equally in terms of their access to resources, care, and opportunities to be better and live well, it is also important to recognize that older adults have unique needs and circumstances that require tailored approaches and additional support. And these, for example, are homebound individuals. Therefore, recognizing the unique needs and circumstances of these populations in an individual level is key. Oral health is also linked to systemic health, and we have been talking about this, and we will continue. While the exact nature of the relationship between oral health and Alzheimer's disease and related dementias is still being explored, several studies have provided insights on this connection, and it is of importance to acknowledge the shared risk factors, such as poor oral health or hygiene practices, smoking, diabetes, chronic inflammatory conditions, and cardiovascular disease. For instance, also several studies also have shown significant association between the number of teeth, remaining teeth, the functional teeth, and the risk of developing Alzheimer's disease or cognitive impairment. And emerging research has also focused on the importance or the level or the status of the oral microbiome and the specific oral bacteria having a potential role on developing Alzheimer's. So when we're taking care of our patients in any role, we need to consider the periodontal health and the disease that is present, the oral microbiome, the tooth retention and tooth loss, the ability to chew and to maintain proper nutrition, the salivary flow, and if it is adequate or it has decreased, and what are the reasons of this, and the level of oral health literacy. In essence, when we look at the pipeline for change and the next steps, we must look at many areas, and this includes mentorship, education, delivery systems, advancing evidence and research to support policy and interventions, technology and innovation, and this is including interoperability of healthcare systems. And this is all to ensure that all areas are covered to make a greater real impact in aging and health. Encouraging interdisciplinary collaboration between oral health professionals, neurologists, and other healthcare providers and researchers becomes imperative in effectively addressing the potential risk between oral health and Alzheimer's disease. To attain a comprehensive understanding of the intricate relationship between oral health and Alzheimer's disease, it is essential to conduct further research encompassing longitudinal and experimental studies, as well as investigations into potential mechanisms. to foster healthcare system transformation that promotes health equity and addresses health disparities, it is crucial to expand access to quality and affordable care while engaging key partners. Furthermore, driving innovation based on identified challenges, considering the sustainability of the programs and recognizing health as a potential modifiable risk factor for Alzheimer's disease are paramount. Finally, to advance the health for older adults, the implementation of best practices and quality improvement initiatives require complex, collaborative, and interprofessional team efforts. A crucial component of this endeavor involves understanding the oral health issues that are associated with systemic health, nutrition, and Alzheimer's disease. By addressing these factors, we can effectively reduce disparities and enhance both the nation's oral and overall health and well-being for all. There is no health without good oral health. I hope this brief presentation and information presented can inspire you all to become leaders and continuing the cycle of including oral health within your work. Thank you very much.
Thank you very much, Dr. Shamut. Very interesting and very informative. Sometime when we're together, I'm going to ask you more questions about George Washington. But right now, we'll move on to the next speaker, Dr. Mansky.
Good afternoon. I'm Rich Mansky, and my topic for today is using observational data and assembling a team to better understand the epidemiology of oral health and Alzheimer's and related dementias. Dr. Shamut, thank you for mentioning George Washington, and I guess it's getting some play. If you notice behind me, what you see is the National Museum of Dentistry. Not mentioned in my bio, one of my other responsibilities is I'm the executive director of the museum. If any of you want to come up to Baltimore, I'll be happy to give you a personal tour. It's a wonderful place, and I think you'll be pleasantly surprised. Today, my goals, my intention is to be somewhat simplistic. I also, in keeping with thinking about tomorrow's workshop, I've designed this to basically set up some thoughts and for the workshops. I'm going to talk about background and gaps. I'm going to talk about data, and I'm going to talk about a research team. I have 15 minutes. Lincoln had 3 minutes to deliver the Gettysburg Address. I guess 15 minutes seems like an eternity compared, but please don't hold me to that level. I will fail remarkably. So what do we know? Well, an association between oral health and systemic health has been well documented. One of the things I'm not going to do is I'm not going to talk about our data products and our papers. If anyone's interested, they're easy to find. Our team has contributed to that knowledge about the association between oral health and systemic health. Studies have provided a biological and epidemiological rationale showing a possible relationship between oral health and specifically periodontitis and various comorbidities, including Alzheimer's and related dementias. Studies suggest that regular preventive oral health care might serve as a protective factor and reduce the risk for Alzheimer's and related dementias among older adults. So if that's the case, why are we here? What are we doing? If it's as simple as that, why not just make sure that everybody has health care, oral health care? Well, interesting, we are each witness to what's been a natural experiment, retirement and the consequent loss of dental insurance coverage upon retirement. Dental coverage is typically employer-based, and as people face the prospect for retirement, they also face loss of income and the loss of dental coverage. And welcome to Medicare. There was some discussion about Medicare earlier. We know that Medicare, for the most part, doesn't provide dental coverage, with the exception of what is needed for a few medical conditions, and that's changing. There's been considerable effort recently about expanding the definition of what's medically necessary. In addition, Medicare Advantage plans often offer dental coverage, mostly as an enticement to get beneficiaries to sign up. Those plans vary greatly in generosity, but they have been having a much more prominent role, and they are increasing. I think there were, well over 30% of all Medicare plans now, and I expect them to continue to increase as we move forward. So, what do we really want to know? It's a simple question. Again, I'm trying to be simplistic about all this. Will providing dental coverage improve oral health? Secondarily, will improving oral health reduce the risk of chronic illness, including Alzheimer's and related dementias? That's what we want to know. We're spending a lot of time during this workshop. We're talking about inflammation, its effect on its systemic effect, P. gingivalis, mechanisms behind periodontitis, pathogens. We're going to probably talk about genes, but that's what we want to know. What do they really want to know about? And what do I mean by they? In my bio, it was mentioned that I provide advice to the professional community. I do, and I get a lot of inquiries. Where are those inquiries coming from? They're coming from Congress. I often get calls from Hill staffers. I get inquiries from the Congressional Budget Office. I get inquiries from professional organizations, payers, users, providers, beneficiaries, and I get inquiries from colleagues. And what they want is they want some assurance that what we think of as the association between oral health and overall health has been well documented. They want assurances. They want to know. They want to make sure that if they're going to spend funds, the policymakers, they're the ones that ask. I've never gotten a call asking me about the pathology or the biological pathways that tie oral health to Alzheimer's. I get calls about, if we spend the money, will there be a net benefit? Or at least will we break even and not lose money? That's what the policymakers are thinking about. And unfortunately, when I'm asked, I have to tell them we can't say for sure. No study has yet to establish a causal relationship between oral health and chronic illness, including Alzheimer's and related dementias. What we have just isn't good enough, and they want more. So, look, we all know this group, NIH, randomized controlled trials, it's the gold standard. The problem is the perfect the enemy of the good? Are the randomized controlled trials, are they practical, are they ethical? And can it be done? And my goal today is to suggest that with the use of observational data, we might not be able to achieve perfection, but we can certainly tear away some of the doubts that people have about the importance of oral health and the importance of oral health as it relates to chronic conditions. In 2021, the Nobel Prize was awarded to Card, Angstrom, and Imbens for their work in showing how observational data can be used to emulate a randomized experiment to identify causal relationships using observational data. They used an instrumental variable approach. And even if you don't buy it, even if you just are part of that camp that insists it is only a randomized controlled trial that can show causality, we need to provide answers. We need to get closer. We need to, if not achieve causality, why not approach causality? Why not learn what we can from what we have? So thinking about observational data, no data is perfect. If you submit a grant, you'll find that out really quick. You'll find out when you get your reviews back. Your reviewers will identify every weakness in the data, everything that's missing. And it's interesting. There was some discussion before about capacity. I think there's somewhat of a disconnect. I think the word out on the street is that the study of observational data is really not favored these days by reviewers, by NIH. And I get it, I understand it, but I think we're missing out on something. I think observational data has the capacity to provide a lot of good information, but there's an art to it. Again, the data is not perfect. You have to be able to figure out, how do I manipulate the data? How do I take the data that may not be exactly what I want and make it work? It requires creativity. But on a positive side, though, it really allows for interdisciplinary work. We can take population level data. We can tie it to chronic conditions data. We can tie it to environmental data. We can tie it to genetic data. You can tie it to biomarkers and biologic data, and you can tie it to medical visit data. And in considering environmental data where people live, you can better consider, equality and disparity in health outcomes. What data is available? There's lots of it out there. The government spends a lot of money on collecting data. I could spend a couple of hours probably on each. On a personal note, I spent a lot of time with MAPS. It's a great data set. There's a lot you can do with it. The Health Interview Survey and Haynes, they each have advantages and disadvantages. I spent a lot of time looking at the Health and Retirement Study. It's a very, very robust study. NIA supports it. It's a wonderful study. One of the nice parts about the Health and Retirement Study is it can be linked to the Chronic Conditions Warehouse of the MCBS. It can also be linked to environmental data from the Area Health Resource Files, and it's longitudinal. You can look at someone over a very long period of time. The linkage of data is very, very valuable. So if you're going to look at observational data, it's a little bit of a catch-22. In order to submit a proposal, you really need some preliminary data. And a lot of what you really need to do a really good job with observational data is often restricted data. And in order to get access to that, you need data use agreements. But most data sets have associated with public use files, PUF files. MEPS does, the Health and Retirement Study does. RAND does a wonderful job of producing some public use files that are associated with the Health and Retirement Study. But obtaining observational data is expensive, it's complex, it's time consuming. It's a word salad of what's out there. Thinking about where you get it, how do you access it? Is it something that's going to sit on my desktop, or is it something that I'm going to have to tunnel in to some distant site to be able to get access to? So it's just something to think of when you want to do one of these projects. But if you are interested in doing this, and by the way, a lot of times now, in order to get access to the restricted data files, you actually have to have an NIH award to get access at all. So you're going to be limited to your public use files in order to develop your preliminary data. Just a word of caution, the rules are changing fast. I'm not going to talk about this other than say, please talk with your project, your PO, discuss with them, look this up. The rules are changing fast, the requirements are changing fast, and it's good for all of us that we're able to share. It's more of a burden but I think we all benefit from it. But I just, offer as a thought, don't leave it for the last minute. It's important, and I would follow through on that. I want to say a few words. I do want to keep to the 15 minutes. I promised that I would do that, so I don't have a lot of time left. I want to talk about the research team. There's a data team and a scientific team, and it depends on the size of the project. So if it's a small project, a lot of times the data team and the scientific team will be the same. But if it is a large project, if you're using something like the health and retirement study, and you're looking at a topic such as Alzheimer's, there is, and you're talking about an interdisciplinary topic, it's going to be a big team. And the data team, in order to manage it, that's going to be a big team as well. And the scientific team will provide guidance to the data team, but it's something that is going to have to be nuanced. And let me get to the next slide. For the data team, if it's a small project on your desktop, you're going to do all this. But if it's a lot of data, you're going to have to think about who has the capacity to actually create the data files, manipulate the data files, do the analysis. Where will the data be stored, and is it secured? That's going to be really important. It's going to be a big part of your consideration. For our interest, we're really thinking about it being interdisciplinary. Who's the anchor? How is this going to be approached? I can tell you from experience, depending upon who is leading the effort, if it's a biostatistician, is it a psychologist? Is it a bench scientist? Is it a policy, someone with a policy background, or is it an economist? They each will have a different spin on it. You have to have one take charge of what the direction is. The methods are similar, but the language and approaches will be different. It's a great opportunity for us that we get to work with a lot of people, but a lot of times it's hard to untangle. So, and I'm going to wrap it up because I only have 17 seconds left. It's important, depending upon what your goal is. If your goal is to be a co-investigator, it doesn't matter as much. But if your goal is to be the PI, you have to, be the conductor amongst so that's it. I'm going to try to keep my word. I like keeping on time. I always promise my students I'll let them out on time, so I'll let you out on time as well. To be the conductor, amongst a lot of chefs in the kitchen. So for the 15 minutes, I hope it was useful. I think the probability of success, we have good prospects to that. Thank you very much for your time. And I look forward to the rest of the session.
Thank you, Dr. Mansky. We'll have some time in the Q&A if you want to elaborate on some of the points that you feel that you could say a little extra on. Let's move on to our next speaker, Dr. Wu.
Yes, can you hear me?
Yes.
Great. Okay. Yeah, thank you so much for inviting me to this workshop. That this is really a very important topic, and I'm glad that more and more individuals from my scientific community are interested in this topic. So today I would like to present my talk that focuses on improving oral health for diverse aging population. So I would like to thank NIA and DCI for supporting my research on the topic of oral health and cognitive function for the past 17 years. So when I first looked into this topic, that was in 2005, 2006. So there was very few people have conducted this line of research. So I remember when I ran into Dr. Anderson, that he's the one developed this Anderson model, health services model. So I explained to him like what I was doing. Then he looked puzzled and intrigued and said, like, really? Please tell me why there's a connection there. So that's how actually this kind of started. Then I kind of explained potential kind of funding pathways linking this kind of oral health and the cognitive function. That's how actually for the past close to 2 decades, our team has been conducting this line of research quite extensively. So, but here that since I've been kind of assigned to talk more about oral health disparities in older adults, so I'm just going to more focus on this topic. So oral health disparity, as Dr. De Souza stated earlier, oral health disparity is a persistent issue in the country. Given there's no publicly funded dental insurance, oral health disparities actually reflect some of the most challenging issues in the United States, including, for example, lack of access to healthcare, lack of dental insurance. Dr. Mansky presented this very well previously, and also reflect the kind of poverty that many people are facing, as well as disparity in the socioeconomic status. So that findings from the recent study using the National Health and Nutrition Examination Survey show that among older adults in the United States, that 20% of older adults had untreated cavity, 20% had indenturism, which means complete tooth loss, and 68% had gum disease, periodontitis. So that poor oral health is really a common but often neglected problem in older adults. So in the following few slides, I will present some of our team study findings on oral health disparities and the relationship between oral health and cognitive impairment in diverse populations. So the first that one of the study we conduct is looking at the oral health and the diabetes. So when this study was to assess the trend of tooth loss and the differences in trend of tooth loss for diabetes, for adults with and without diabetes and across racial ethnic groups. So we actually combined 9 waves of the national survey data that enhanced between 1991 to 2012, and basically looking at tooth loss in relationship with diabetes over 40 years period. So this is a kind of this slide actually certainly presents several kind of key findings I want to emphasize here. So here the solid line represent those with diabetes, and here that vertical line is the predicted tooth loss. Then the horizontal line is the years from 1971 to 2011 or 2012. So the dotted line is for those individuals without diabetes. So the solid line, the first one, that certainly you can see that here there was a significant, during 1971 to 2012, there was a significant decreasing trend in the number of teeth lost. So older adults with diabetes experience about twice the tooth loss as did those without diabetes. So this, the first line, solid line for African Americans with diabetes. Then you look at the first line for the dotted line is African Americans without diabetes. And then you look at this, the middle line, the blue line, solid line for white Caucasians. And then the middle line for the dotted line is also for white Caucasians. So that's that overall you compare that this is for across these 3 groups, Mexican, white, and African Americans, their relative positions actually in terms of the kind of a tooth loss has not changed for the, over the past 40 years. But overall, there's a decreasing number of teeth individuals had tooth loss, which means more and more people are retaining their natural teeth. So here that overall, when you look at this, the estimated number of teeth loss that has among non-Hispanic Blacks with diabetes increased more with age than those among non-Hispanic whites with diabetes or Mexican Americans. So there's certainly there was a decreasing kind of trend in number of T cells among for all three groups. Adults with diabetes experience about twice the T cells as those without diabetes. But I'm also was very pleased that in Dr. De Soto's presentation this morning, she actually already presented the findings from this study. This is our team's study published in 2021. So when I remember our first paper looking into this was 2007, 2008. But for the past 16 years or so, there's a significant increase number of studies looking into the linkages between oral health and the cognitive impairment and dementia. So our systematic review found that older adults with more tooth loss had a 1.48 times higher risk of developing cognitive impairment and a 1.28 times higher risk of being diagnosed with dementia after controlling for other factors. When we did this meta-analysis, we further kind of found that each additional missing tooth was associated with 1.4% increased risk of cognitive impairment and a 1.1% increased risk of being diagnosed with dementia. So then we look at this study just published recently, early this year. We looked at tooth loss, periodontal disease, and the mild cognitive impairment among Hispanic, Latino immigrants, and particularly examined the moderating effect of age at the immigration. So here, that this study, we used the data from the Hispanic Community Health Study, study of Latinos, and its ancillary study, the study of Latinos investigation of neurocognitive aging. So then our study found that there was an increased risk of having mild cognitive impairment for those immigrants who had a significant tooth loss, which is 8 teeth lost, and immigrate to United States at age 35 to 40 years old, in comparison to those who younger immigrants who immigrate to this country younger than 18 years old. So overall, this is the kind of figure. So here's we have like 4 age groups. One is for those immigrants younger than 18. Then 2 is immigrant between age 18 to 34. Then 3 means age 35 to 49, age of immigration, and the 4 is 50 and over. So you look at this, we highlighted this rectangular kind of figure here, that these are the kind of age. Look at the upper level line, red line, is for those significant tooth loss. Then the bottom line is for those not significant tooth loss. But here is the predicted probability. The vertical line is a predicted probability of MCI. So you clearly see those that the significant differences between in this age group, immigrant age 35 to 49. That the probability of there's a high risk of mild cognitive impairment for this immigrant population who have significant tooth loss, which is that has eight or more tooth loss, and the immigrant to the United States between the age of 35 to 49 years old. This means that those who had lost 8 or more teeth and came to the US at this age range are more likely to have mild cognitive impairment than those who retained more teeth or immigrant at a younger age. So Journal of Gerontology Medical Sciences just this month published a commentary on this manuscript. And they particularly state that this paper highlights the need to understand the diverse segment of the Hispanic population that may be underrepresented or overlooked when utilizing data from other national surveys. It also emphasized the importance of promoting optimal and health among older adults as a key component of promoting healthy aging, which may help mitigate the development of a mild cognitive impairment. So, so here that I would like to present another finding which is related to this, in terms of this topic, in terms of the racial ethnic disparity in trajectory of dental service use in the US. So again, we use the 5 waves of the health and retirement study, which Dr. Mansky mentioned this HRS data, that we use the data from 2006 to 2014. And here is the, this is a kind of a busy figure, but overall that this figure visualizes age trajectories of the rate of dental services. That's a longitudinal study, same individual followed for kind of 10 years. So find the trajectory of the rate of dental service use. This figure shows that for both the US born, which on the left-hand side, and the foreign born, the trajectory of services used tended to decline with increasing age. So that's the kind of a trajectory for each. Here's white, here then the African Americans and Hispanics and other race groups. So the trajectory, the general pattern was true for most racial ethnic groups that showed a substantial decline after age 80 or so. This is very much true when you look at the other groups. There's a significant decline of dental service use after age 80. However, that for white, their average level of service use showed a sign of a slight increase before age 80, and then an insignificant decline afterwards. So it's a kind of a bit moderate or small decline for white overall. They start from age 50, right, to look at that for till age 100 or so. But you look at other minority populations, significant decrease in terms of dental service use after it's already seen actually age 60 or age 70 or age 80. That's the kind of sign for both US born and foreign born. So overall racial ethnic disparities in dental care was substantial and persistent as people become older, regardless of nativity, while adjusting for a wide range of covariates. So here that the last few slides, I want to kind of show this, that how we think about improving oral health in diverse aging population. That this is the conceptual framework that we developed based on social determinants of health, as well as some other conceptual frameworks. And it came up with this conceptual framework, particularly was targeted to immigrants and looking at this integrated framework of immigration, aging, and oral health. We need to have a better understanding, think about how kind of oral health disparities that in later life, what are the factors? This is a very much complex kind of factors intertwined together, have impact on oral health in later life. But this can also apply to many other health outcomes as well. To think about from birth to aging, there's under the large contextual factors, think about social, cultural, economics, political, commercial context. Then here's like individual factors looking at demographics and other biological, genetic factors, physical and cognitive health. But when you particularly look at the immigration factors, the place of birth, reasons for immigration, immigration status, acculturation. There's many other factors look at environmental factors, behavior factors, psychological factors. But more also, I would like to emphasize on this pre-immigration antecedents. Don't forget these individuals as immigrants, they bring their own culture, they bring the characteristics to this country. That is actually many of the early life conditions before immigration, characteristics of country of origin, access to and uptake of oral health services in their kind of sending countries has a profound impact on their health outcomes in later life. So here that I would like to draw upon this the paper that as a part of our GSA oral health work group, we published a white paper looking at how some potential solutions to improve oral health. There's a medical coverage of oral health services, medical expansion, Medicare expansion of dental services is critically important. Get people to care about oral health in older adults, drive awareness of the economic and humanistic value of better oral health for older adults through health promotion and the public relations campaign targeting consumer, caregivers, health professionals, and other oral health champions and researchers. Some of our previous presenters also has touched upon some of these issues. And think about practice of the future, there's integration of oral health into general health, change the oral health care delivery system from care delivery solo to more general and robust healthcare system, make oral health as part of primary care, change the scope of dental practice from dental to oral health as a holistic approach. They integrate integrate dental and the medical education. They integrate finance and interprofessional practices. Thank you very much.
Thank you so much, Dr. Wu. Really, really great talks and all very informative. Now we will open the room for any questions. Can either raise your hand if you have a question or put them in the chat.
Miriam, so I have a few questions I'd like to start with if nobody else is jumping in at the moment.
Yeah, sure. I don't see any questions in the chat or any hands, so go ahead.
Oh, okay. For Dr. Shamut, does it make sense to have a geriatric dental care specialty, or should training in geriatric care be enhanced within the broader dental education?
I think it's very important that we push the needle into making dental geriatric a specialty, a recognized specialty for two things. I ended up in geriatrics by accident, because I was doing my rotation and I fell in love of aging individuals and people living in nursing homes. I saw the neglect, and that led me to pursue dental public health. But when in the dental school, we're not really exposed to geriatric at the level of other specialties. So because people are not going to the dentist, for example, or the access or transportations are limitations. So the geriatric component within the dental curriculum is limited at the moment. So even though we're working with accreditation bodies on including more hours and more curriculum component on geriatrics, the geriatric population often faces more challenges and complex medical conditions that should be acknowledged. And as a dental providers, when we graduate, not often we are trained to handle all these medical complexities, and it can be frightening. So people are pushing back themselves if they're not being exposed or they don't feel comfortable at providing the care, because it's more challenging, but also more complex, and the reimbursement models are not there yet. So they would rather provide care to easier population or healthier population per se. And that is one problem. So training geriatric dentists is very well needed, because you need a wider understanding of the complexities of older adults, and also the care that we provide to older adults is a little more, you have to adapt it, because for example, you have to go and travel to them rather than they coming to you, especially when they're more frail. So there are some adaptations that we need to learn as dental providers, and it is really well needed. So if everybody is working on dental education, I know that there has been talks, but also the funding for these geriatric specialties is not there. So a lot of geriatric training programs are closing across the country, and that becomes a challenge. And people are not applying. So for example, at Harvard, we have a geriatric dental program, but finding candidates to apply is very challenging, especially from the US. So a lot of people from other countries are applying, but they're returning back to their countries to provide the care. And we're not retaining any of those individuals in the country. So we're becoming less and less people in trained in geriatrics. So that is really an issue.
Well, thank you. Just in looking at my own experience with dentists, it doesn't seem like our current model fits very well with having like people who specialize in the older population. You know, it's like you just sort of, you stay with your dentist until he ages out, and then you find a new dentist, and eventually you age out, right? But you're not searching for a special geriatric dentist or anything. Miriam, I see we've got some other people wanting to raise questions now. Why don't you go ahead with that?
Sure. Yeah, we have a couple of questions in the chat. So first, why tooth loss also increases risk of cardiovascular disease? Guess that's for all of the speakers. Does any of the speakers want to answer that?
I think it, go ahead, you go, Dr. Wynn.
Oh, yeah, Dr. Minsky, please, go ahead.
So it actually, it sort of touches on one of the bigger issues. What are we really observing when we see oral health as a predictor of chronic illnesses? Is it the oral health directly, or is the oral health a proxy for something else? There are a number of other factors that are also associated, and that's been part of the problem. We haven't been able to tease that out. So it gets to the big issue. So, you know, you're looking for a biological pathway to sort of explain tooth loss does this does that ends up with cardiovascular disease. That hasn't yet been completely untangled. I mean, the general discussion is always about inflammation. Inflammation's the link, you know, on everything. But I think a lot of times, you know, it's poor oral health, just a proxy for lots of other kind of health behaviors that aren't favorable to overall health. And I think that's one of the things we have to be honest about amongst ourselves. And, you know, for the real believers, and those are the people, some of the people that I get inquiries from, I really want to be able to give them the answer they want. And I can't tell them what they want to hear yet. I can't tell them no, but so you're identifying a big problem that we're discussing. And it's actually one of the reasons I advocate for studies of observational data, because you can't do this in a lab. You're just not going to solve this doing bench work. You're going to solve this using big sets of data that are interlinked and doing some detective work, trying to understand what is underlying, and then seeing, you know, what is a reasonable biological pathway that would follow along with the results that's being produced by the data. I hope that gives you a little bit of an answer.
Yeah, certainly this is well said, Dr. Minsky, that oral health that can be proxy for many other kind of underlying factors. And some are also that some can be not observed and cannot currently not measured in many of the large studies. So we need to be aware of. But some kind of think about hypothesis-wise, some potential kind of pathways in relation that we all think about information, as Dr. Mansky mentioned, but as well as actually, for example, kind of nutrition intake, right? To think that mastication that affect the nutrition intake, these kind of factors can be also related to cardiovascular disease. And also similarly to think about cognitive decline as well. So these are some kind of a potential pathways or linkages that we can think about.
Okay, thank you. Dr. Shamuk, do you want to add anything?
Well, I just really echo Dr. Wu and Dr. Mansky's comments. And I just want everybody to think it's really difficult when we're trying to share information to non-dental providers, but as individuals, everybody has probably suffered from oral pain. And when you have that pain, it's one of the greatest pain that you can have. And that really deters you to do your activities of daily living and what you can eat that day, even for one minor toothache. When you have a cavity and you cannot drink water properly, and when you are eating sugar, it hurts more. So just to think of about like not having one tooth is one thing, but when you're missing several and based on the location, the quality of the way that you are chewing that food and how that is ingested and how your body goes beyond not just the mouth, but the digestive system. So it's hard to tell what affects what, but everything is linked to the mouth. And that's why we really want to raise the importance of putting the mouth in the work that we're doing. Everybody's doing great research or great work, but if we think how to incorporate oral health in a way, we can find those answers.
Thank you. Okay, so our next question, I think, is more for NIH, but maybe our speakers have some experience that they want to share. So for junior faculty, are there key awards that might be geared towards examining oral health and aging? Dallas, do you want to start?
I wish we had our training officer here to talk about that. I should think that there's a way that it can be done, but I don't have the specifics of it.
Yeah, I see that someone put the link. Preeti, thank you so much. Put the link to the training, I think, program, the NIA train, or this is the NIDCR actually, training program. But you can also search for the NIA training in career development office and reach out to them. But just let Dallas.
I can add one thing, coming from NIDCR, so they have a program that is on research and you can tailor it. It's more about dental public health. So this is for dentists. And now it's a research component. So it's like 3 years and you can find that information at the NIDCR website. But if you're interested in aging, when I completed that program, I was able to conduct research with the Administration of Community Living on aging. So you tailor, so that is one program that I know about from NIH. It's not a K, but you do the training in the Bethesda campus.
Dr. Anderson, could I just make a quick comment about your first question?
Yeah.
So, you asked the question about should we have more specialists or better train our generalists? The answer is yes and yes. Dentistry is organized a little bit differently. The issue is about how people are referred. So it's a question of numbers. I just don't think that there is enough numbers for a large program, but for a small program where you have centers, maybe at dental schools or in, large academic health centers, there could be a need for a dental specialist in geriatrics. But across, dentistry, the problem you're facing about, your practitioner aging out and then you aging out, I think it's no different than with your primary care provider in all aspects of healthcare. So, but I do think it's a function of how dentistry is organized.
Yeah, that was my thought, that that we're really bound by the way the system is organized. And do you have a sense that in other countries it's done differently? And so
yeah, I'm not aware. I mean, generally the dental students are trained to handle complex, patients with complex conditions. Some may choose to have a practice that is truly general, inclusive. Others may not just be interested in it. So, maybe there's a need to encourage more practitioners to take ongoing. I mean, look, education's lifelong learning. So maybe, continuing education, maybe it's health literacy, maybe it's provider literacy about the importance of it. Maybe that's something, that needs to be done, is sort of that messaging.
Very good. Miriam, do we have more questions?
Yes, we have more. So the next question is for Dr. Wu. I know Asian Americans were probably captured in the other category of some of your figures, but can you speak to any unique patterns or experiences for older adult Asian Americans in their oral health?
Thank you for the question. Actually, I took out a few slides in the last moment because to think about the time for my presentation. We actually conducted a study looking at oral health and cognitive function, cognitive decline among Chinese American older adults using a large cohort, the PINE study for 3,000 some individuals, Chinese American. We found some link between oral health symptoms and global cognitive function, the decline of global health, global cognition. So this is the findings are somewhat similar to what I presented among Latino populations. I think overall that all these kind of immigrants we need to pay more attention is possibly this is their oral health literacy is somewhat lower, and also awareness of the importance of oral health and access to dental care. These are barriers probably more salient for immigrant populations by large.
Thank you so much. So the next question is for any of the speakers. Presumably, oral health during childhood sets the stage for oral health later in life. What are the barriers to providing low-cost interventions to improve oral health in children? Are there economic incentives to such interventions in terms of cost-benefit assessments? How do early interventions compare to interventions later in life? Does any of the speakers want to take that question?
I'm trying to look at the question because it was a little long, but the answer is yes, because there is some research that it works two ways. When you're exposed to certain foods, so you are already setting into the path of how you're growing, how like the behaviors. And if you're having low nutritious food, for example, and you can grow into an obese stage or develop diabetes at an early stage. So that is the nutrition part is a great component that is setting the stage into a healthy aging or unhealthy aging per se. So there is a scaring of the organs that we don't see, and there is evidence and published research on that area. So I can take a look and then post it in a little bit in the chat.
Yeah, I think part of the problem is the time span from early childhood to late life. I don't think we have any data that will, that actually has that. But I would point you to some work that's been done by Brandy Lipton. There was a paper in the Health Affairs, look for that, and I think there was in one of the adjuncts to the New England Journal of Medicine. If you look for Brandy Lipton's papers, there were two that looked at the relationship between early and a little bit later, but not much later. I'd point you to that. That might be helpful. I was part of that team.
And one more thing, as for the interventions, dental sealants are very important, especially in first molars and second molars. So that is one intervention that as a public health specialist, we're really trying to do for children. And because sealing the pit and fissures are gonna reduce the risk of developing tooth decay in those important teeth and can reduce the risk of tooth loss.
Thank you. Thank you for the question and for the answers. Right, the next question. Are you aware of any paper comparing systemic markers in people with and without tooth loss?
So if you let me share a screen, I'll quickly show this. And again, I didn't talk about any of our work before, but this is something that you can look up. It was in Journal of Dental Research and looked at edentulosum and systemic health among older adults. And this was supported by an R56 provided by NIA. So here's, I would refer you to this paper.
Thank you so much, Dr. Mansky. Anyone else want to add anything on that question? Great. I don't see any other questions in chat.
So Miriam, I got an answer from our training officer. I posted it in the chat so everybody can see it, but basically I'll just read it. It says, while there are no K-NOFOs, that's our new term for funding opportunities, focused on oral health and aging, the applicant may choose the parent K01 or the K08, K23, depending on their type of degree and whether they are proposing basic science or patient-oriented research. So there's a way to there's a way forward. You just choose the right mechanism.
Wonderful. Thank you. Dallas, did you have any other questions that you wanted to ask our speakers before we end this session? Oh, Dr. Noble has a question.
Yeah, thank you. I put it into the chat, but I think it got lost up above. Maybe Dr.
Sorry.
Wu, that's okay. That's okay. Dr. Wu, maybe you can field this one. I mean, the question I had posed is, are we really facing an issue of people not knowing that they ought to take care of their teeth? I would argue that probably is not an avenue of research worth pursuing. Most people know that they ought to take care of themselves, whether it's their teeth or their general health. It always comes down to a matter of cost versus value. And if there's no support, no financial support whatsoever for somebody to take care of their teeth, then the value relative to cost is out of balance. And if you think of, in comparison, primary and preventative care, diabetes and hypertension and the like, generally speaking, have full coverage, if not near full coverage. And so the value decisions become almost moot when cost is basically erased. So, your work, Dr. Wu, would suggest that, depending on the group you look at, upwards of 75 to 80% of all people are accessing care. But if the issue is not so much about knowledge, but really true access to care, and that comes down to insurance coverage, shouldn't that actually be, not so much even an area of study, but just something that ought to be addressed rather than spending years more trying to figure out why people don't go to the dentist?
Yeah, actually, go ahead, you go first. I want to jump in.
There's actually several comments here that I would like to point out. That certainly it is about priority. That when you look at older adults, first of all, this is about priority. When for older adults, they may facing a lot of health problems, then you think about the ladder, right? Which one kind of they want to kind of think about first. Taking care of their brain, yes, certainly this is really important. Think about some kind of heart disease or diabetes. Think about this. That's the kind of one kind of issue to think about priority, but also that cost, as I said in my presentation, the finance certainly is very important factor to think about this, and also that's why lack of dental insurance. Think about expansion of Medicare coverage. That we need to kind of have a national discussion at the kind of national platform to think about this. But also, let's think about some other cultural factors when you particularly look at the immigrant population. For example, even like from our own studies, when you look at this, many old adults don't see routine checkup is a kind of, they need to do that for routine dental checkup. Unless they have kind of tooth symptoms like tooth pain or some other kind of issues, that they start thinking about, oh, geez, I need to seek a dental care. That actually went from international studies that our study conducted in China and found similar kind of issues. Even like, for example, our relatives will think, why you want to see a dentist on a regular basis? Actually, this kind of dental thing may loosen your teeth. Well, that's the kind of reaction that we see. So let's think about, it's a very complex, again, that cultural factors certainly play a role in immigrant population as well.
Yeah, can I just add to that about the general population? First of all, in terms of use rates, 80% is pretty high. We've used multiple data sets. We've looked at NHANES, NHIS, MEPS, Health and Retirement Study. The number is probably in the high 50s of the, over a 1-year period, the percentage of the population that would visit a dentist. Also, my health literacy colleagues would probably question the idea that people really know that they should take care of their teeth. And what does that really mean? Taking care of your teeth to one person may be quite different than taking care of your teeth to someone else. So I think there's a real need for health promotion, health literacy. I wouldn't make that presumption.
I want to add one more thing, and I agree with Dr. Noble that a lot of the problem is with the access and the insurance piece, but also health literacy plays a very big issue, especially among older adults, for two things. A lot of older adults are relying on others because they're frail and they are relying on others to get the care that they need. If the caregiver doesn't know enough that the mouth should be clean and all the protocols, or even if they had dentures, I have seen so many cases in nursing homes that the nurses didn't know that the patient had dentures and they never removed those. And so that is one problem. And also a lot of older adults are receiving several medical prescription medications that are leading to dry mouth. So that dry mouth is going to increase the risk of developing caries or root caries, as Dr. D'Souza mentioned earlier. So that is a huge problem within the older population itself. And we're not trying to change the medical protocols or the prescription medications, but if they know that the medication will cause dry mouth and will increase the risk of developing caries, they should have a protocol to reduce the risk of dry mouth itself. And medical providers in general, they're not addressing that issue. They're prescribing, but they're not really truly advising the side effects on their protocols. So that is another issue that I want to raise concern.
Thank you so much. Anything else that anyone wants to add? Dallas, anything else?
No, not at this point.
Okay, great. Then this is the end of our session 1. Thank you all so much. Thanks to the speakers for the great presentations, and to everyone for the great discussion. We will now take our lunch break, and we will be back at 2:20 to start our session 2, biology, mechanism, oral microbiome, and Alzheimer's disease. So see you all back at 2:20. Director for the neurobiology of aging and neurodegeneration branch of the Division of Neuroscience at the NIA, and a member of the workshop planning committee. And Dr. Yilmaz is a professor and chair at the Medical University of South Carolina in the Oral Health Sciences Department. So I'll hand it over to Dr. Marek and Dr. Yilmaz.
Thank you, Mariam. So again, welcome to the session 2, Biology, Mechanisms, Oral Microbiome, and Alzheimer's Disease. As you heard this morning, the oral health, and particularly periodontal disease that may lead to tooth decay or loss.
Maya, your sound is breaking out. I don't know if it's just me or others. Can others hear her well?
Yes, I can hear the same.
Okay, I will stop my video. And do you hear me now any better?
Yes, sounds better now.
So let me know, interrupt me if sound goes bad again. So I just wanted to summarize that we heard this morning that the oral health, and particularly periodontal disease that may lead to tooth decay and loss, certainly has larger effects on overall physical health, particularly in older population. And we also learned about epidemiological, educational, and social aspects, and the need for a multidisciplinary approach and support. Now we are turning our focus on identifying and understanding biology and potential biological mechanisms that form oral health and Alzheimer's disease axis. We hope that this kind of research may uncover potential targets for prevention or cure for oral and neurodegenerative and other diseases common to aging population. As Dr. Mansky mentioned also, it is not clear yet what biological pathways connect tooth loss and inflammatory diseases like cardiovascular diseases. I would like first to introduce in a little bit more depth my co-chair and then other speakers. It is my pleasure to introduce Dr. Özlem Yilmaz, a professor and chair at the Medical University of South Carolina in the Oral Health Sciences Department. She holds a doctorate of dentistry from Istanbul University in Istanbul, Turkey, and PhD in oral biology from the University of Washington, Seattle, where she also pursued postdoctoral work in the Department of Global Health. Yes.
Your sound, yes, sometimes it's okay, but sometimes it doesn't sound very clear.
I don't know what to do about it.
Do you want to try calling in?
Perhaps Dr. Jonas can take over?
Yeah, I'll be happy to do so, Mariam, if this is okay with you. I know there might be some technical issues. Yes, thank you so much, Maya, for being so kind and so complimentary. I'll just continue where she left because she kind of provided me the, if this happens, she provided me the copy of her basically introductory remarks. I did my postdoctoral degree studies in the global health in the University of Washington, and I was a tenure faculty member in periodontology and oral biology departments at the University of Florida, Gainesville, for a decade prior to joining the Department of Oral Health Sciences at NIAC in 2016. Basically, my lab has a long-running interest in the pathogenic and immune evasion mechanisms deployed by opportunistic periodontal pathobionts, especially Porphyromonas gingivalis. And my lab's research efforts have included the pioneering the development of imaging and other ways of measuring the assessment of anaerobic bacterial invasion in situ, as well as detailed exploration of the secreted microbial molecules and mechanisms involved in evading and blocking immune responses for host invasion. I've been placed in the top 1 most cited scientists in the disciplines of microbiology and dentistry since 2017, and my work was supported by NIDCR, NIA, and NIAID now. Our first speaker today will be, it's my pleasure to also introduce my dear colleague, Dr. George Hadjishengelis, who's DDS, PhD, and he's Thomas W. Evans Centennial Professor at University of Pennsylvania. Dr. Hadjishengelis holds a doctorate degree in dentistry from the University of Athens and a PhD in microbiology and immunology from the University of Alabama, Birmingham. His field of interest is the host-microbe interface, where his work has eliminated novel mechanisms of microbial dysbiosis and inflammation, also in the context of aging. And he is actually one of the key, he's one of the major name creators for the keystone pathogen hypothesis for P. gingivalis. More recently, the Hadjishengelis lab has identified maladaptive myelopoiesis as the mechanistic basis for the bidirectional association of distinct inflammatory comorbidities. He combines basic and translational research leading to innovative approaches to clinical problems, such as those exemplified by periodontitis, where his preclinical work has recently led to a successful complement-targeted phase 2 clinical trial in patients with periodontal inflammation. He published in numerous high-profile scientific journals and one of the highly cited researchers for the past 5 years. He's a member of the scientific advisory boards of the Aging Conferences, the Foresight Institute, and NIDCR Board of Scientific Counselors. And Dr. Hadjishengelis is a recipient of quite a number of awards for his contributions to science. As we are going through all the speaker information, I will be jumping myself as a second speaker to our third speaker, Dr. Alexandru Movila. Dr. Alexandru Movila is currently an associate professor at Indiana University School of Dentistry and director of Imaging Core at Indiana Center for Musculoskeletal Health. He has expertise in aging biology, oral microbiology, and neuroinflammation. Dr. Movila's research focuses on understanding molecular mechanisms behind the connection between periodontitis and Alzheimer's disease and related dementia in relation to age and sex. In addition, his lab is interested in understanding the pathophysiology of sphingolipids metabolism in age-associated systemic inflammation and oral cancer. The research program of the laboratory is mainly supported by the NIA and NIDCR grants. Last but not least is of our fourth speaker, I should say also your comments will come after that, Stephen Domini. Dr. Domini is an MD and also he's the co-founder and chief scientific officer of Lighthouse Pharmaceuticals, a clinical stage pharmaceutical company. He also maintains a staff position at Stanford University as a research scientist in the Department of Bioengineering. Prior to this, Dr. Domini was the co-founder and chief scientific officer of Cortex Time. With Dr. Domini, he will share his spotlight with Yorka Munoz, who is Dr. Munoz is a postdoctoral fellow at the Faculty of Medicine and Health Sciences in the Department of Neurology and Neurosurgery at McGill University in Canada. Dr. Munoz trained with Dr. Professor Marco Tulio Nunes lab at the University of Chile, where she studied neurodegenerative diseases, in particular Alzheimer's and Parkinson's diseases. She studied the toxicity of beta amyloid in astrocytic neuronal communication, which is an in vitro model of Alzheimer's disease. And she started to study the correlation between periodontal disease and Alzheimer's disease in collaborative work. Dr. Yorka Munoz is a well-published young scientist who presented works at more than 15 international conferences. Dr. Munoz has been awarded with 8 national scholarships and 6 international fellowships from diverse scientific institutions, such as the International Brain Research Organization and the International Society of Neurochemistry, among others. I think this concludes all our outstanding speakers, and without further ado, we will give the floor to Dr. George Hadjishengelis.
Thank you very much, Özlem. Let me share my screen. Can you see my slides?
Yes, we can.
Okay. I would also like to thank the organizers for the invitation to this exciting workshop. And I will be speaking about periodontal disease and its systemic impact. So periodontal disease is a disease that affects the tissues that surround and support the teeth, that is the gingiva and the alveolar bone mostly. This is a quite prevalent disease. In its severe form, it affects about 10% of the adult population, and it is the 6th most prevalent condition worldwide. It involves a tremendous expenditure, and it increases the risk of systemic inflammatory diseases. There is therefore an unmet need for host modulation. And in that regard, with our collaborators, we have developed a complement-targeted host modulation therapy in periodontal disease. And recently, we have completed a phase 2A clinical trial that was successful. And patients that were treated with this complement inhibitor had significantly reduced clinical inflammation. Our next step is to go through a phase 3 clinical trial. So the periodontal disease is associated with a number of systemic comorbidities, including Alzheimer's disease. And I would like to present an overview of the mechanism that may be responsible for this association. So one is common susceptibility. This does not imply any causal relationship between periodontal disease and other comorbidities, but there are 2 other categories in which periodontal disease may be playing a causal role. The microbiome could have direct effects, and I will show some examples. And also the microbiome is also responsible for systemic inflammation, which in turn can also cause or exacerbate systemic diseases. Now, about common susceptibility, as I said, this does not imply any causal relationship. For example, if 2 diseases share common biological pathways, then let's say a defective allele would be able to affect both diseases. And I will just give an example from our own work to demonstrate this concept. DEL1 is a homeostatic protein that is expressed in the gingiva and the central nervous system, and it regulates neutrophil infiltration and Th17 cells activation. Also, DEL1 expression is diminished in old age, and it was not surprisingly that we found that in old mice that have very little DEL1, there was increased in neutrophilic inflammation, also increased IL-17 production, and that was strongly correlated, of course, with increased bone loss. So this is for periodontal disease. Now, in DEL1 deficiency also resulted in increased neuroinflammation and loss of myelin in a mouse model of experimental multiple sclerosis. Going now to direct effects of the microbiome, there are papers showing that oral bacteria can ectopically colonize the gut and induce dysbiosis, which can lead to diseases like colitis. Also, in other cases, bacteria can disseminate to the brain by the blood-brain barrier and cause neuroinflammation. And you will hear more about this in another talk today. Now, bacteria that can translocate into the circulation, causing bacteremias. This is associated with increased inflammation, systemic inflammation. And systemic inflammation is sensed by the bone marrow, where we can have development of maladaptive inflammatory memory. But because this is a new concept, let me take a step back. And just a second here. Let me take a step back and introduce this concept of innate immune memory, which is interchangeably known also as trained immunity. So by saying trained immunity, we mean the ability of the innate immune system to form epigenetic memory and elicit enhanced immune responses to secondary challenges. So this is what happens when, let's say, a macrophage sees a bacterium in the first place, but it can respond by memorizing this infection. It can respond much stronger and faster when it sees this microbe or a different one. It's not a specific form of a memory like it is in the adaptive immune system. Now, this is an evolutionary developed, evolved mechanism that can protect us against infection or even against tumors, and there is scientific evidence, experimental evidence for that. But like everything in immunity, nothing can be 100% protective. There's also the dark side, and trained immunity can also exacerbate chronic inflammation, in which case we talk about maladaptive trained immunity. So what we have shown recently is that systemic inflammation that is associated with periodontal disease can be sensed in the bone marrow by hematopoietic progenitors. These progenitors develop inflammatory memory, which is passed on through epigenetic mechanisms to their myeloid progeny, which of course will not stay in the bone marrow. They are free to circulate, and they can go back to the oral tissues and exacerbate periodontitis, but they're also free to go to extraoral tissues as long as there is inflammation or some infection there. So in a model of arthritis, we have shown that this mechanism exacerbates arthritis. So in other words, maladaptive trained immunity that was created by periodontitis exacerbates not only periodontitis, but also another systemic disease. And one might say that, yes, that was work developed in an animal model. That's correct. But if we go back to old literature, clinical periodontal literature, we see signs that suggest generation of inflammatory memory also in humans. So there are many studies showing that if you get peripheral blood from periodontitis patients and you try to stimulate their neutrophils or monocytes ex vivo, let's say with LPS or bacteria, there is much more production of inflammatory cytokines than if you get cells from periodontally healthy controls. And not only that, this trained phenotype is not reversed, it is maintained even after successful periodontal therapy. In fact, there was also a study that showed that even after extraction of hopeless teeth, that memory was maintained. So at that time, it was not called innate immune memory, but it was something that was surprising and could not be explained by the knowledge of that day. And this is from a more recent work. This is a clinical imaging study by a group in Boston. And they have shown a very nice correlation between periodontal inflammation and increased hematopoietic tissue activity in the bone marrow, which suggests that there is a so-called periodontitis bone marrow inflammatory axis, exactly as we have seen in the mouse model. Now, I don't want you to think that maladaptive trained immunity is specific for periodontal disease and arthritis. It could be, for example, between periodontal disease and Alzheimer's disease. That is one of our focus today. Of course, this has to be shown experimentally. But again, this mechanism is so central that it could connect, in principle, any two systemic inflammatory diseases. Now, as you understood from my brief description of trained immunity or innate immune memory, this is an epigenetically based memory, which means that it is in principle reversible. It's long-term. In humans, it can go 14, 15 months at least. In mice, several months, but it's in principle reversible. Now, is there any pathological condition where this maladaptive epigenetic alteration could be fixed, in other words, in a permanent state? In other words, another situation like maladaptive trained immunity, as bad as it is, or even worse? And unfortunately, the answer is there is. And here I would like to introduce very briefly again the concept of clonal hematopoiesis of indeterminate potential, or CHIP, also a relatively recent concept. So what is CHIP? Now, as we get older, our hematopoietic stem and progenitor cells accumulate somatic mutations. Some of these mutations confer a self-renewal and proliferative advantage to the mutant cell. So you can understand that this mutant cell is going to produce a lot of other cells that look like it, a clonal expansion. Now, this mutant hematopoietic progeny give rise to a great fraction, an outsized fraction of mutant cells, myeloid cells, let's say neutrophils and monocytes, and also T cells. And these mutant progeny cells are often found to be hyperinflammatory. These mutations that cause CHIP, they mostly frequently affect the genes that encode, this is not surprising, epigenetic modifiers, epigenetic enzyme modifiers like DNMT3 and TET2. And this is why I said before that this is another form that you have maladaptive epigenetic changes. And this is also a quite prevalent condition and affects more than 10% of individuals that are older than 65. It has been shown both epidemiologically and at the experimental level in animal models that CHIP is strongly associated with cardiovascular disease. So the question we have asked in our lab is whether CHIP can also cause or get associated with periodontal disease and rheumatoid arthritis. And in that regard, we have been collaborating with Kimon Tivaris from a clinical or epidemiological point of view. And the analysis of the participants of the ARIC study revealed that CHIP, and particularly those CHIP carriers with mutations in DNMT3A, are strongly correlated with increased prevalence of periodontal disease and also with the extent of gingival inflammation. Now, of course, this does not imply a cause and effect. This is an epidemiological association, but this is why we have animal models to address potential causation. Here I would like to say that the most frequent mutation that affects the DNMT3A enzyme is the R8082H. It's considered a hotspot mutation, and the equivalent mutation in mice is R878H. We have these mice, and we wanted to explore this causal association between CHIP on DNMT3A and periodontal disease. But we do not use these mice as such because all of their hematopoietic progenitors are mutant, and in humans it's only a fraction. So this is why we use their bone marrow and transplant 10% of the bone marrow with 90% from healthy bone marrow, and thus we have a 10% clonality in the recipients, which is clinically relevant. So the experimental mice are getting 10% of mutant clones, and the control recipient mice, they will get 10% of wild type clones, together, of course, with a 90% to make 100% wild type clones. So we follow this, the expansion of these clones in the experimental animals and the controls. And as you can see that with time, the mutant clones expand, whereas the wild type clones stay at the same level. Now, in these mice, 12 weeks after transplantation, without doing anything, just by looking at their bone levels, we have seen that they have developed naturally occurring bone loss, which was associated with increased inflammation in the periodontal tissue, some of the cytokines, just to mention, IL-1 beta, IL-6, IL-17, and also rancor. So in other words, the expansion of the mutant clones in the recipient mice caused naturally occurring periodontal inflammation and bone loss, providing a strong evidence that CHIP can lead to periodontal disease. Now, in similarly treated mice, we subjected them to collagen antibody-induced arthritis. Both groups of mice developed severe arthritis, but those mice that received the mutant clones, the mutant CHIP clones, had increased arthritis clinically and also histopathologically, and also that was associated with increased infiltration with inflammatory cells. So we can see from this preclinical evidence that CHIP could be a mechanistic basis that could connect to inflammatory comorbidities. In our case, we looked at periodontal disease and arthritis, but again, this is not specific for these two diseases. It could be, for example, periodontal disease and Alzheimer's disease. So all I want to say is that CHIP, especially since it appears in the elderly, could be a major mechanism that could connect periodontal disease and other systemic comorbidities, including Alzheimer's disease. Of course, there is more work in that regard to be done. And the important thing is not only to describe a pathological mechanism, but to find a treatment to benefit the patients. And in our lab right now, we are trying methods to block the expansion of the CHIP mutant clones, and in this way to also block their detrimental effects on inflammatory diseases such as periodontal disease and other. So with that, I'm done, but I would like to thank the people in my lab for contributing to these studies. And the studies that I presented today were mostly done by people in my lab, Xiaofei Li, who is now an independent PI, and Hui Wang. Also, of course, to help our collaborators, without whom we would not be able to do all this work. The group of Triantafylus havakis in Dresden, Germany, Mihai Netea in the Netherlands, Kim Divaris at UNC, and my complement collaborators, John Labris and also Hatice Hasturk, who performed the clinical trial that I mentioned at the Forsyth Center. And of course, to thank the NIH and especially NIDCR for their generous support all these years, including these studies. And thank you for your attention.
Well, thank you, George. Very, very interesting talk. Well, for the interest of time, I will start my presentation and I will go, I will close my video so you can see the images maybe better. And George, if you could close your video, maybe
yes.
I'll go to presentation mode as well. Thank you.
Yes. Is it okay now, Aslam?
I think so. Let me go to share. So hopefully that will remove you and put me on the.
I stopped sharing. I hope it worked.
Yeah. I'm trying to applications. screen. Sorry for that. Thank you for your patience. Okay. All right. I hope everybody can see it now.
Yes, we see.
Thank you. Well, again, we had wonderful talks today, and I'd like to also talk. I would like to also thank the organizing committee of NIA coming up with such a timely and very interesting topic of symposium. And thanks for the kind invitation. My area as a dentist and trained microbiologist and cell biologist has been, my focus has been on the biology of infections and particularly Porphyromonas gingivalis biology and its invasion into tissues, which has been less covered today. I know many of us think about microbes, microbiome as a sort of an external entity and it sheds into the environment, which is a major contributor in many regards for the systemic inflammation. However, we have another side of the some microbes. They can go into tissues, and that is very, very difficult situation for the anyone to really interfere. With that, I'd like to say a little bit about the microbial ecology. It has been mentioned today many times, but I'd like to emphasize a couple of things. In the mouth, we have very rich, diverse communities and species. With the current knowledge, with the technology we have, we know that there are over 700 species present in the human oral cavity. And most of the time, these highly complex microorganisms really live in a commensal harmony with their host, with human host. And when and if the ecological catastrophes occur, which we know it can, and it's one of the best examples is the periodontal disease, we see a large shift in the oral microbiota if we are specifically talking about this area where the periodontal disease ensues. We see a large shift of obligate anaerobic and non-sugar fermenting microbes are appearing. Among those, Porphyromonas gingivalis really takes the lead in many regards. Not only this is a highly studied microorganism, it is also the highly detected microorganism in the diseased people, as well as in the healthy people in the low levels. We know this microorganism can be in low levels, can be present in everyone's mouth. And because it has the ability to really competitively live in the both oral biofilm and the intracellular host environments, it can be very versatile, and I think that makes the microorganism so successful, and therefore it has been involved in a variety of systemic disease etiologies. And not only now the Alzheimer disease and related dementia, many other studies are showing the oral cancer or the oral digestive cancer specific associations, as well as rheumatoid arthritis. Another major unique properties of this microorganism is that it has very different unique virulence properties, not necessarily present in the other microbes. And I think the ability to chronically be present in the oral mucosa and other tissues is a very interesting feature for a microorganism can go external and contribute to biofilm, because most of the time when we look at the bacterial kingdom, we see either the microbes or the bacteria, in this case, develop mechanisms to be highly competitive in the intracellular environment, but they are not necessarily very good in the oral biofilm or the biofilm formats. So due to the fact that this microorganism has so many virulence properties, it becomes really highly adaptive. With this, we know we and others have characterized many hemostatic pathways being targeted by this microorganism, in making highly compatible in the host systems. As you can see, this is a human primary gingival epithelial cells heavily infected by the microorganism, and the cells are not really bothered, and they are going to cell division. Another important aspect of this microorganism is that to be able to create this very special form of autophagic vacuoles. These autophagic vacuoles are non-canonical, which we call them selective autophagy, and they are probacterial. They don't really, these double membrane vesicles are highly specialized and highly rich in the ER structures. They don't really fuse with the lysosomes, and they really serve as a very helpful non-hostile replicative niches for the microorganism to persist in the human gingival epithelial cells. We also know that the microorganism, as it reaches its own, level of good infection, it can really separate from cell to cell. And in the in vitro human primary epithelial cell systems, we've shown that that's time dependent, and it can occur through the actin cytoskeleton and the help of the microtubules as well. This provides truly the organism to evade the immune system detection and be perpetually present in the human oral mucosa. And again, just bringing you all to the fact that this microorganism is highly sneaky in terms of getting into the human tissue and being there, persisting, and having the ability to be in the capillaries. Those are small vasculature formed upon periodontitis in those gingival tissues, and potentially having its way to the systemic locations. Because what we have been studying in P. gingivalis and what we have really read and contributed in the literature with P. gingivalis contribution to chronic systemic diseases, it was timely for me and for my lab to connect with the experts in the Medical University of South Carolina. In the Department of Pathology and Laboratory Medicine, it provided me the opportunity, the collaborators I will mention in the acknowledgement, provided me opportunity to get into access of those very important Alzheimer's disease-related dementia post-mortem samples, brain samples. Those are verified samples for the disease, and with that, we were highly interested to specifically to look at the area that we thought might be the first place of initiation of blood-brain barrier access of the microorganism to brain in the perivasculature, which was the gyrus area, temporal gyrus. And when we look at our samples coming from the non-ADRD patients who has other severe systemic conditions, we did not see the presence of the bacteria, as you can see. And this is the H&E staining for the same samples. And to our large surprise, we have seen excessive amount of P. gingivalis presence in the perivascular and the endothelial lining of those blood vessels, the arteries, we believe they are, in the temporal gyrus. And if you look at those colonies, which we call colonies because the morphological aspect of the staining we are seeing with this imaging is suggesting those are really truly intact P. gingivalis colonies, and they are absolutely in a living stage with the look they do present. And these are the infected walls of the arteries, the blood vessels with P. gingivalis. This finding led us to look at more deeper, and we try to look at a little bit more superior part of the brain, temporal gyrus, where we know that neurons will be more present. And then we were able to see the heavily infected neurons are present in those disease patients, but not in the non-ADRD patient samples. Naturally, we thought about looking at the CSF to sort of further confirm the entry of the microorganism to the brain and also its clearance from the brain. And when we look at the CSF samples of those individuals, either has Alzheimer and related dementia versus no dementia, both early and the late have increased number of genomic DNA of P. gingivalis. Signals were really high. We also have some low-level presence of P. gingivalis in the non-ADRD patients. They are all, by the way, I forgot to mention, age match samples, and all our non-ADRD patients almost have some other systemic major problems, but they do not have the pathology presentation of ADRD in their samples. When we look at the P. gingivalis and tau localizations, this is regular tau, not cis tau. We have also seen in the hippocampus region of these individuals, there was a high infection of P. gingivalis present, and the infection really correlated with the high level of tau accumulation, and there was a large level of tau and P. gingivalis co-localization in those patients' samples. Simultaneously, we have developed mice studies by using the wild type black mice, and we have fed the mice orally with P. gingivalis for 29 weeks. And these mice were 10 weeks old when we start oral feeding of P. gingivalis. And during our behavioral studies, especially in the open field test at 28 weeks, it was really significant that we've seen a highly increased risk-taking behavior in the mice that has been inoculated with PG, as opposed to mice that receive vehicle. We have not seen that type of risk-taking behavior. Basically, the mice that have received the P. gingivalis tend to go to the center and spend time there, whereas the mice has no P. gingivalis introduction, mostly stay in the corners. And the distance traveled between those two groups of mice were equal, very comparable. These mice also, when we look at their brain tissues, we have seen large level of infection in the cerebellum. Those cells we believe are Purkinje cells in the cerebellum are heavily infected. And we have found a large level of infection in the medulla and cortex regions of the mice at the 29 week of post-infection. And important things from those initial findings were the level of infections in the biogeography of the infection or invasion of PG really correlated with the severity of the high risk-taking behavior in those mice. And also we have seen the more infection, there was a more tau accumulation in the respective regions. And all those mice develop signs of periodontal disease determined by the alveolar bone loss and also gingival inflammation, although they may differ in the severity of periodontal disease. We are trying to understand now if that correlates with the level of the risk-taking behavior and other pathologies we are determining. Our future direction is to go and study this in a mechanistic level by identifying molecular targets for the treatment of ADRD in the context of chronic oral microbial infection. And this will be across the various understudied cell types of brain perivascular structures and not limited to only brain endothelial cell types. And that we will be also we will be looking at the interface between the brain perivascular structures and the neurons for future. I'd like to acknowledge my laboratory members and my faculty collaborators. I'd like to specifically thank Bridget Welsleger, who is my PhD student. She's an amazing microscopist. She took those great pictures. And Dr. Nidhyanda Chowdhury, who has done the mice nucleation studies, Dr. Ryan McDaniel Mims, who has done the whole analysis on the brain of those mice, and all my laboratory members, and especially my collaborators in the Department of Pathology, Dr. Önder Albayram, the mentor, Dr. Adviye Ergül, and Dr. Eric Hamlet, who have been so generous with their time and their generosity for providing those very precious samples to us. And also the chair of the Department of Pathology and Laboratory Medicine in USC, and my other collaborators in various parts of the world, including in Toronto. I'd like to thank everybody and thanks for listening. Our next speaker is I will stop sharing first. And our next speaker is, I believe, Dr.
It is Dr. Alexandru Movila from Indiana University.
Thank you, Dr. Movila. I apologize. Please go ahead, Dr. Movila.
Sir, when you go ahead and put it in presentation mode, and then at the top, you'll see display settings.
Hello, everyone. Can you hear me now?
Yes, we can.
Yes, sir. Yes, sir. But could you please put your presentation in presentation mode?
Hold on.
Okay, you just stopped sharing.
Yeah, I can see that. Okay. For some reason. Is it in presentation mode now? No.
It's still waiting. Okay, no, sir, it's not.
Let me do something different. Okay.
So you had it in presentation mode before, but it's just that we were seeing the presenter's view. We just needed to swap the views.
Yeah, that's what I'm kind of surprised why. Can you see now?
Okay, go ahead and put it in presentation mode.
Presentation mode. I'm sorry for the inconvenience.
No, sir, you're fine. Okay, now go ahead and put it in presentation mode. Don't stop sharing. Go ahead and put it in presentation mode.
Where is it? Because it's not showing up.
Okay, if you click slideshow at the very top where it says file home, you'll see slideshow right next to animations.
Next to the anime. This.
At the very top. Oh.
Nope.
Okay. Okay, yeah, right where you're at, keep going over, you'll see slideshow. Okay, now click display settings.
And
Click on
swap.
that and then swap.
Perfect.
Okay, there you go, sir. You're all set.
Nice. That's awesome. Hello, everybody. I'm so sorry for the inconvenience. Hopefully now it will work. So I'm Alex Mavila. I'm faculty from Indiana University School for Dentistry. And as was mentioned previously, I'm also director of imaging facility at the Indiana Center for Musculoskeletal Health. I have actually dual expertise. One came from the neuroinflammation part, and then I did another postdoctoral training focusing on periodontitis and oral bacteria. So later, when I became a faculty, I decided to combine both expertises, and I'm going to share with you what we're actually doing now in my lab in the next 15 minutes. So the major overview, what I'm going to talk today. First of all, we were talking a lot about periodontitis and Alzheimer's disease today, and I will try to kind of show my vision of view, and I'm always trying to understand actually the chicken or the egg philosophy between periodontitis and Alzheimer's disease. After that, I will share a couple of slides about the impact of sex. Unfortunately, we were not really focusing on that problem today. Maybe later speakers will do, but I will show what we are doing in terms of sex-dependent promotion of periodontitis and Alzheimer's disease. And at the end, I will show you a work in progress when we are trying to understand how actually specific signaling, which share some common signaling molecules, are engaged in both periodontitis and Alzheimer's disease, of course, in relation to sex. So, but if you check, so we will discuss about the microbiome problem today in relation to periodontitis and Alzheimer's, but in general, we also have to keep in mind that let's call it, there is a good microbiome when we have actually, which keeps our teeth healthy, gut healthy. I'm not talking a lot about the gut today, and of course, keeping our brain and mind hopefully healthy as well. But on the other hand, when we have dysbiosis, in addition to periodontitis, which actually I want to tell to those who are not really familiar with periodontitis, that we have massive inflammation mediated by a number of bacteria, and a lot of my colleagues actually were mentioning about that. But at the end of, actually one of the outcome of the periodontitis is massive alveolar bone loss, and the person can lose the tooth at the end. This is one actually part of the story. On the other actually problem part, we have Alzheimer's disease, which is also could be linked by dysbiosis, and the person developing a severe portion of neuroinflammation, neurodegenerations. And one of the major outcomes of Alzheimer's disease is pathogenic amyloidogenesis, hyperphosphorylation of tau, and neuroinflammation. And if you see from this actually slides, there is kind of common word, I think, which could be linked together, these two pathologies is neuroinflammation, motor inflammation from the brain pathology, and inflammation from the oral pathology. And what is important to know that, as was mentioned in previous actually topics, that oral pathogens were detected in both in oral actually is linked to oral health and the brain health as well. But the question which I'm keep asking myself actually, who is the first person who developing periodontitis has a chance to develop Alzheimer's disease, or those who have Alzheimer's disease have a greater chance to develop periodontitis? So I answer that, but let me share with you what we actually studying in our lab. And we recently published a paper which partially addressed this question, but later I decided, so maybe instead of focusing more on Porphyromonas gingivalis, which is one of the key pathogens, we decided to talk more about experimental models of dysbiosis and how it's linked to the between periodontitis disease and Alzheimer's disease. Some facts, what we know already. So from one side, it's clear that periodontitis is more common in males. So a lot of actually studies showing that. But on the other hand, Alzheimer's disease is more prevalent in females. And I just recently opened the WHO website, and I found that approximately 55 million people are affected by Alzheimer's disease. And unfortunately, we're expecting near 10 million new cases every year. But what makes me a little bit worried that we are primarily focused how periodontitis links to the Alzheimer's disease. But on the other hand, we have already 55 million people with Alzheimer's disease, and we still don't know how to treat periodontitis. We don't have actually any established protocols, but it is well established that people with Alzheimer's disease and related dementia, they have elevated levels of bone loss, including periodontitis. So for that purpose, we're trying to understand first if Alzheimer's disease is actually promoting periodontal bone loss. This is first arm of my study. So we actually checked published papers, and I'm sorry if I didn't include all publications, because now there are a lot of publications coming from my colleagues, but I just selected 2 publications from Dr. Zhang and Dr. Kantakis group. And they used 2 animal models. One is APP knock-in mouse model, and another one is pretty common model 5X-FAT. Both of them are models for Alzheimer's disease, and of course, when they induce periodontitis using different experimental models, they found that Alzheimer's mice developing significantly stronger periodontal bone loss compared to the wild type control. And it was proposed that they have initially elevated levels of inflammation without even having periodontal lesions. So they are naturally losing the bone. But what we still don't know the impact of sex in this process, because unfortunately in many publications only one sex is used, either males or females. To answer these questions, I'm in collaboration with my colleagues from Moldova State University of Medicine and Pharmacy. We started a small study where we collected males and females with dementia. You probably know that it's very hard to say if the person has either Alzheimer's disease or any type of other dementias when the person is alive. So we called it people with dementia. We were expecting that they have a higher level of Alzheimer's, but we were sure that they don't have Parkinson's disease. So it's Alzheimer's like dementia, let's call it this way. But when we collected GCF from them and did analysis, we found that the level of rankle, which is indication of bone loss in general, is linked to the osteoclastogenesis, was significantly higher in females compared to males. Furthermore, the periodontal probing depth again was significantly higher in females than males, which actually made us a little bit worried, because initially, as I said at the beginning of my talk, it was clear that, believed at least, that males developing more periodontal disease than females. But in our case, we found that females with dementia have elevated risk of periodontal disease than males. Then we analyzed GCF from periodontal pocket for the well-known factors affiliated with Alzheimer's disease. It's amyloid beta and p-tau, and we found similar relationships showing that GCF from females have higher level of both amyloid beta 42 and p-tau compared to males. Having this information, we decided to actually check these results using Alzheimer's disease-like experimental model, and we choose triple transgenic Alzheimer's disease mice for a reason, because 5X-FAT and APP knock-in mice, they're developing really aggressive Alzheimer's disease. 60G mice are also not ideal, unfortunately, for this type of studies, but they are slowly developing Alzheimer's disease, because we have to keep in mind there is Alzheimer's disease related to genetics, And there is actually non-genetically related Alzheimer's disease called late onset Alzheimer's disease. So to induce periodontitis, we place a ligature. It's a well-known model. And using the ligature, we kind of mimicking dysbiosis in those mice. And after that, we measured several outcomes for osteoclast activity, alveolar bone loss, and GCF for rank amyloid beta and p-tau, which is kind of similar to what we did for human studies. And when we collected actually GCF, we found again similar results in female 3XTG mice. So once we induce the ligature, we see that it's dramatically elevated for amyloid beta and p-tau actually in females compared to males. And what actually made me a little bit worried that we haven't seen any statistical significance in amyloid beta and p-tau in 3XTG mice with ligature compared to control. And as expected, neither amyloid beta and p-tau were detected in control animals. Next, we checked for the activity of cathepsin K, which is a well-known marker for osteoclast activity in vivo using intravital imaging techniques. We ejected mice with cathepsin K activity dye, and 24 hours later, we actually were really surprised, found that the cathepsin K activity, or we call it osteoclast activity, was dramatically elevated in females with ligatures in 3XTG mice compared to the actually males. And again, no big difference was detected between males, which actually clear indications that females are at higher risk of developing periodontal bone loss when we are trying to link it to the Alzheimer's disease pathology. And our micro-CT data showed exactly the same data as we just discussed for cathepsin K activity. Next, actually, we decided, okay, we have high level of bone loss in ligature-induced periodontitis in relation to 3XTG phenotype. How about the brain? So those mice were actually of course, euthanized, and we collected the brain. And after histological examination for amyloid beta and p-tau, we will really be surprised that in response to ligature, female mice have elevated levels of amyloid beta and p-tau in the cortex. And again, no big difference was detected in males. So just a brief summary for what we found, that it's clear that sex plays a significant role in the bidirectional link between periodontitis and Alzheimer's disease. But then later we asked us, okay, what is the potential mechanism could be involved in this process? And after reading the literature, there is actually a beautiful review published in Bone Research where actually authors try to link what is known about the signaling between macrophages, microglia, and osteoclasts, because all of them are coming kind of from the same family of cells, with some exceptions, of course. And they actually summarize, showing that there are 4 major receptors engaged in this process. And because of the time limitation, I'm just going to talk about one potential signaling pathway through the CF1R receptor. Actually, this receptor is highly expressed in all 3 populations of cells, in macrophages, osteoclasts, and microglial cells. But what really important to know is CCF, there is a typo here, I'm sorry, CCF colony stimulation factor 1, actually signaling is really important for keeping all these 3 population cells happy and healthy. So it's required for their homeostasis. And it's well known that there are actually 2 potential ligands for this receptor. It's either well-known macrophage colony stimulation factor or IL-34. Both of them binds to the same receptor and promoting all 3 types proliferation. In addition to that, if you apply the rankles, then these cells will be actually fused and make major osteoclast. So we tested the impact of IL-34 and MCSF on the proliferation of macrophages, microglial, and osteoclast in relation to the Alzheimer's disease pathology. But just briefly, let me step down and tell a little bit what is known about IL-34 versus MCSF. Yeah.
Time allocation, is that finish soon?
Yeah, I'm almost done.
Thank you.
Yeah. Sorry, I used my time to establish. So just what we found when we proliferated cells toward IL-34 and MCSF, we found again the same results, and macrophages from females dramatically produce more pro-inflammatory cytokines comparing to those from males. Similar results was obtained from microglia cells. Furthermore, when we exposed osteoclast precursors either to amyloid beta 40 or 42, which is well known for the promotion of Alzheimer's disease, in the presence of IL-34, MCSF, and ANCA, primary IL-34 proliferated osteoclast precursors were dramatically became TRAP-positive multinucleated osteoclast. Same results when we checked for the expression of IL-34 and MCSF in the brain in ligature-induced models. We found that in the presence of ligature, IL-34 was dramatically elevated in the hippocampus of females comparing to the males. And the last but not least slide is our work in progress. So we try to understand what if we will use neutralizing antibodies against IL-34 and MCSF. We found that when we injected anti-IL-34 monoclonal antibody into the ligature-induced periodontitis lesion, we were able to stop actually periodontitis from development, but we don't know how it will affect brain in those animals. And just brief summary that IL-34 is dramatically elevated in the hippocampus of female males, but not males. The one of my limitations, actually, we use only one mouse model, so we need to test different available animal models for Alzheimer's disease and related dementia. And just what I want to tell you is our home take message that both sex and IL-34 are one of the key factors underlying the connection between periodontal dysbiosis and Alzheimer's disease. I would like to thank all my current lab members and former, some of them are actually attending the meeting today. I also would like to thank my collaborators from Stark Neuroscience Institute, Dr. Bruce Lamb and his group, and Dr. Michelle Bloch, who actually helped me to establish microglial project here. I didn't show all results. My former colleagues from Nova Southeastern University and Force Institute, actually not former, they are still current, we're collaborating closely. And my PI, Dr. Kawai, actually I did a wonderful training under his mentorship, and I would not present my work without his support. And of course, NIH, especially NIA and NIDCR, who provided us funds. And we are open for any type of collaboration. Thank you so much for your attention, and I'm sorry that I took some extra time to present my work.
Thank you. And we are moving to Dr. Domini now. Dr. Domini, after you finish, we will have Dr. Minos continuing.
Yes.
We are really over time now. Thank you, Dr. Domini and Dr. Ogda.
Can you see my screen?
Yes, we can. Thank you. I think you need to go to presentation mode now.
There we go.
Perfect. Thank you.
Okay, I would like to thank the organizers of this workshop for inviting me back. I previously spoke at the NIA 2021 workshop on infectious diseases and Alzheimer's disease. These are my disclosures. I do have some conflict of interest. I'm a co-inventor on gingipane inhibitor patents that I will talk about today. First, some background. 2018, Keiko Watanabe's lab published a landmark paper demonstrating that oral infection of wild-type mice with P. gingivalis induces AD-like pathology. After 22 weeks, pgDNA and gingipain antigens could be detected in the hippocampus. As many of you know, gingipains are cysteine protease virulence factors of PG and consist of arginine gingipains that cleave proteins after arginine residues and lysine gingipains that cleave proteins after lysine residues. Gingipains are essential for PG survival and pathogenicity, playing critical roles in host colonization, inactivation of host defenses, iron and nutrient acquisition, and tissue destruction. Gingipain antigens were shown to localize in microglia, astrocytes, and neurons, and there was a significant increased expression of inflammatory cytokines, and neurodegeneration was evident in the experimental group. Importantly, amyloid precursor protein and base1 gene expression were increased, and extracellular A-beta 1 to 42 was detected in brain parenchyma in response to the infection, consistent with evidence that A-beta 1 to 42 is the antimicrobial peptide of the innate immune system. Additionally, the PG infection induced phosphorylation of tau. We followed Watanabe's paper in 2019, reporting on the discovery of gingipains in Alzheimer's disease brains. This paper reports on the identification of gingipains in AD brains and the rationale for the development of small molecule gingipain inhibitors to target PG and AD. I'll use the results in this paper to guide the first part of my presentation. Then we'll present results from our large randomized clinical trial specifically targeting P. gingivalis with a gingipain inhibitor in mild to moderate Alzheimer's disease. In summary, gingipain levels in brain correlated with AD diagnosis and tau and ubiquitin pathology. Gingipains were shown to be directly neurotoxic and fragment tau. An oral infection of wild-type mice with PG resulted in PG brain invasion and induction of A-beta 1 to 42 that could be blocked by small molecule gingipain inhibitors. Both arginine gingipain B, which is abbreviated RGPB, and lysine gingipain, abbreviated KGP, in brain independently demonstrated a significant correlation with AD diagnosis, tau load, and ubiquitin load. Non-dependent control samples revealed a continuum of gingipain pathology consistent with the concept of preclinical AD. Intraneuronal gingipain was confirmed in neurons of AD hippocampus. Gingipain was shown to co-localize with tau tangles and intraneuronal A-beta. An immunogold technique was used for electron microscopy detection of arginine gingipain in the AD middle temporal gyrus. The gingipain antigen was detected within endothelial cells lining blood vessels, near and within cell nuclei, and within synapses, but perhaps the most important findings involved mitochondria. The arginine gingipain positive PG outer membrane vessel-like structures were identified near mitochondria. In figure A, you can see a gingipain-studded spherical particle near an intact mitochondrion. Figure B is a larger image of the gingipain-studded OMV-like particle. In figure C, from the same subject, you can see several gingipain antigens inside a swollen mitochondrion with evidence of damaged cristae. Figure D from a different AD brain shows a similar abnormal appearing mitochondrion and the presence of several gingipain antigens within. It is known that gram-negative bacteria use outer membrane vesicles to deliver mitochondrial toxins. We determined through a series of experiments that when PG infects a cell containing tau, tau is fragmented, and that the fragmentation is gingipain dependent. We subsequently identified gingipain cleavage sites in tau and the resulting tau fragments. Increased levels of phospho-tau217 in CSF and blood have been identified as biomarkers for AD. In brain lysates from CVN mice orally infected with PG for 5 weeks, the levels of phospho-tau217 were significantly greater than mock-infected controls. Mouse brain A-beta 1 to 42 increased significantly after oral infection with PG compared to mock infection or mice treated with the KGP inhibitor COR119. Mice infected with RGP or KGP knockout strains of PG had brain A-beta 1 to 42 levels no different than mock infected. In vitro, A-beta 1 to 42 co-localized to the surface of PG and significantly increased PG death compared to A-beta 1 to 40, A-beta 1 to 42 scrambled, and PBS vehicle control. This is consistent, again, with evidence that A-beta 1 to 42 is an antimicrobial peptide. Oral administration of a KGP inhibitor effectively treated PG brain infection and prevented loss of hippocampal interneurons in vivo. A lead compound was identified, the lysine gingipain inhibitor COR388, and underwent preclinical and IND-enabling studies. It underwent a phase 1 trial and then entered into a large phase 2/3 clinical trial, which I will report on now. The phase 2/3 trial of atuziginstat reported here was conducted to assess the safety, efficacy, and tolerability of atuzumab over 48 weeks in subjects, male or female, 55 to 80 years of age, and generally healthy with a documented clinical diagnosis of mild to moderate probable AD dementia according to the NIA 2011 criteria based on a differential diagnosis and a mini mental state examination score of 12 to 24. Now, this is important. We chose not to enroll subjects based on the 2018 NIA amyloid tau neurodegeneration criteria or the ATN criteria that would represent amyloid positivity, because this would limit our ability to determine if PG infection was associated with cognitive decline in subjects that did not have abnormal amyloid levels, for example, suspected non-Alzheimer pathology. We also chose not to select subjects based on PG infection biomarkers, as we did not know beforehand what the prevalence of PG infection was in the probable AD population or what the best biofluid or biomarker for PG infection would be. Instead, in the statistical analysis plan, pre-specified subgroup analyses were pre-specified for PCR analysis of PG DNA and saliva, ELISA analysis of PG-specific IgG, and serum and CSF to determine PG infection status of participants. Cognitive function, as measured by the Alzheimer's Disease Assessment Scale Cognitive Subscale, known as ADAS-COG, was the primary endpoint pre-specified for proof of concept. This was a global study with greater than 90 sites in the US, France, Spain, Poland, and Netherlands. Now, again, remember, we didn't select anybody on any biomarkers, including no periodontal disease biomarkers, but we did do a sub-study of 233 subjects. 90% were diagnosed with moderate to severe periodontal disease based on pocket depth and attachment loss measures. 98% of subjects at baseline were positive for serum anti-PG IgG. The N was 638 on that. And 78% had high PG antibody levels associated with periodontal disease. Baseline CSF anti-PG IgG levels indicated PG CNS infection, that's a central nervous system infection, in 98% of 491 gained subjects who underwent lumbar puncture. Anti-PG IgG concentration CSF was largely independent of the albumin index, indicating central nervous system production of the antibodies. Only 2% of gained subjects had loss of blood-brain barrier integrity as measured by the albumin index greater than 9. The presence of these antibodies in CSF supported a direct PG infection in the central nervous system. In CSF, we measured the CSF A-beta 42/40 ratio and p-tau 181 levels in 488 subjects and applied the 2018 NIA Alzheimer's Research Framework criteria to determine what diagnostic subgroups are present. In the upper left quadrant, amyloid positive and phospho-tau positive is designated Alzheimer's disease according to the research framework criteria. As can be seen, 76% of the 488 subjects would be classified as having Alzheimer's disease. In the lower left quadrant, the amyloid positive and phospho-tau negative profiles designated Alzheimer continuum. 7.8% of subjects would be classified as such. In the upper right quadrant, the amyloid negative but phospho-tau positive profile is considered suspected non-Alzheimer pathology. 9.4% of subjects would therefore be classified as having what is known as SNAP. In the lower right quadrant, the amyloid negative and phospho-tau negative profile is considered to have, quote, normal AD biomarkers, but as we know that these subjects also have mild to moderate dementia. This group represents 6.7% of the cohort that had CSF obtained. Efficacy was demonstrated in the pre-specified PG positive and saliva population. On the left, you can see in the 643 subject intent to treat population that there is not an efficacy signal. However, in the pre-specified population with PCR evidence of PG in saliva, which represented 38% of the ITT population, equal to 244 subjects, there was a dose response efficacy signal with 80 milligram twice a day dose slowing cognitive decline by 57% with a p-value of 0.02, and the 40 milligram twice daily dose slowing cognitive decline by 42% with a p-value of 0.07 over 48 weeks. On the right, in the subgroup that is PG negative in saliva, there's not an efficacy signal. Benefits were also seen in other cohorts defined by pre-specified PG infection markers, with saliva PG PCR detection the most robust marker. Pre-specified high anti-PG IgG in serum, median split also demonstrated significant cognitive slowing with 80 milligram BID atuzumab dose, whereas the high anti-PG IgG in CSF median split was not as robust a marker as the other two markers. Analysis of medians support the conclusions of the primary analysis. In the graph on the left, subgingival plaque samples were obtained in the periodontal substudy at 24 weeks and 48 weeks, and lysine gingipain activity was measured with a lysine gingipain activity probe. The 40 milligram dose of atuzumab showed significant reduction of lysine gingipain activity at 24 weeks, and the 80 milligram dose showed significant reduction of lysine gingipain activity at both 24 weeks and 48 weeks. The graph on the right shows serum anti-PG antibody percent change from baseline at week 48 was significant for both the 40 milligram dose and the 80 milligram dose. So after presenting the preclinical and clinical data above, I wanted to revisit the 2018 NIAA paper, which shifted the definition of AD in living people from a syndromal to a biological construct based on in vivo biomarkers. I'm displaying figure 6, hypothesis testing using the research framework. Figures A through F represent various possible mechanistic pathways that involve A beta, which is represented as A, phosphotau, which is T, and neurodegeneration marker, which is N, and cognition, which is C. The mechanistic pathway denoted in A represents the current paradigm I think everybody's familiar with. However, the preclinical and clinical data I have presented today best fits the hypothetical pathway shown in figure F, where A represents A beta, and A beta is present here because it is an antimicrobial response to the infection, and T represents phosphotau is present because, as I showed before, is induced by the infection. And Z, or PG, and the gingipains directly cause neurodegeneration and cognitive decline through fundamental mechanisms such as gingipain proteolysis of tau, gingipain damage of neuronal mitochondria, etc. So, what is the next step for an atuzumab confirmatory clinical trial enriched with mild to moderate dementia patients with PG positive saliva? Well, the drug development business is a tough business, and unfortunately, even though atuzumab was generally well tolerated in the GAIN trial, there was evidence that it was causing liver enzyme elevations in some subjects, and further development of the drug was discontinued, and a second-generation lysine gingipain inhibitor was developed that recently completed a phase 1 trial. The next-generation lysine gingipain inhibitor is LHP-588, recently completed phase 1 single ascending dose, multiple ascending dose study. No evidence of abnormal liver enzyme elevations at any dose. And the pharmacokinetics were consistent with once-a-day dosing at 25 to 50 milligrams, and once-a-day dosing obviously would be better than twice-a-day dosing in the demented population. The phase 2b trial of LHP-588 and PG-associated Alzheimer's disease incorporates learnings from the GAIN trial. Key eligibility criteria will include you have to have a PG positive saliva test, mild to moderate dementia, and since we won't be performing lumbar punctures to obtain CSF in this trial, we'll use plasma p-tau217 as an AD biomarker, especially since we saw induction of p-tau217 in an animal model. We recently completed a pre-IND meeting with the FDA just last month. So in summary, extensive convergent data support the role of p-gingivalis and its gingipain virulence factors as upstream drivers of AD prior to the GAIN trial. The GAIN trial with atuzumab was the first ever large clinical trial specifically targeting PG with an orally bioavailable brain-penetrant gingipain inhibitor. And we saw approximately 40 to 50% slowing of cognitive decline in mild to moderate AD with PG positive saliva. The next generation inhibitor, LHP-588, is de-risked for hepatic safety, will be tested in mild to moderate AD with PG positive saliva. And it's highly differentiated from amyloid targeting therapies. The spring trial is scheduled to start in 2024. And I'd like to thank this core team led by Casey Lynch, Leslie Holsinger, Florian Ermini, Deborah Raha, Ursula Haddish, Shireen Kapoor, Mai Nguyen, Andre Conradi, Joanna Bolger, and Mike Decky for running this trial during the height of the pandemic and getting it done on time. We also have important advisory board and other academic collaborators. Many of you probably know Jan Patempa and Barbara Patempa, Hatisa Sturk, Eric Reynolds, Maurice Curtis, Mike Dragonel, Leon French, Marwan Sabal, and Mark Ryder. We had many, many development partners, clinical trial site personnel, study participants, and caregivers. Thank you.
Thank you, Dr. Domini. Can Dr. Munoz start immediately? Then we will go to questions and answers as we are really over time. Thank you.
Sure. Can you see my screen?
Not yet, Dr. Munoz. You started, but it says double click to enter full screen mode.
No,
Yeah,
it's still loading in Zoom for us to see.
Oh, sorry.
Okay, if you could put it in presentation mode, please.
Can you see me now?
Yes, ma'am. Looks good.
Okay, thank you so much. So, I'm Yorka Munoz. I'm really happy to be invited to this meeting. I'm a postdoctoral fellow in Murray's lab at the McGill University. And today I want to just to present very briefly some part of my research that is a performance gingivalis infection in Down syndrome and in non-human primate model and possible role in neurodegeneration. So just a brief introduction. Down syndrome is characterized by the replication that can be complete or partial of the chromosome 21. The strong association between Down syndrome and Alzheimer has a genetic basis. Many genes associated with Alzheimer's are located in the chromosome 21, including the amyloid precursor protein, among others. So, and you see in the left, the A-beta accumulation starts early during childhood or adolescence, and after 30 years, there is a neurofibril tangles accumulation and a progressive inflammation and oxidative stress. So after 40 years of age, there is an increase of the severity of the AD pathology. The individuals with Down syndrome show immunodeficiency and activation of the innate immune system. Infections are frequent in those individuals, including respiratory infections, hepatitis B, and periodontitis, which is a chronic and aggressive. Several studies have suggested a strong association between periodontitis and Alzheimer's. And Porphyromonas gingivalis is the keystone pathogen involved in periodontitis, and he is highly prevalent in children with Down syndrome over 5 years. There is a strong correlation between this bacterium and the severity of the disease. So this bacterium display potent virulent factors, including the gingivans, which are extracellular arginine lysine proteases, crucial for the inactivation of the host defense, colonization, survival, and tissue destruction. So just I would like to mention that evidence suggests that young adults with Down syndrome shown an exacerbate and a new neuroinflammatory profile before developing AD pathology, and that profile is completely different, but we can see in AD. So first, we analyzed the presence of gingivalis and the gingivans in different human tissues using immunofluorescence. So a specific neural enolase, it was used as a neural marker, and gingivans were identified with a monoclonal antibody. Gingivans can be observed intracellularly in neurons in AD, Down syndrome, and even in the control age matched individuals. However, P gingivalis low was higher in Down syndrome than Alzheimer's, and those neurons they are highly infected, don't express the neuronal marker enolase. So at the right, you can see that dense extracellular or intracellular gingivin and P gingivalis positive aggregates were frequent in hippocampus and temporal cortex of individuals with Down syndrome. Gingivins colocalize also with astrocytes, as I show you here, and colocalize with showing aggregates in the cellular body. You can see in the yellow arrowheads. And microglia also show some colocalization occasionally. So in individuals over 40 years of age, extracellular DNA was frequent, and they contain PG positive aggregates, as you can see in that area, in the yellow area. Astrocytes show reactivity and polarization towards those areas of extracellular DNA. Microglial cells are also active and showing phenotypes with a low number of branches and roll-like shape. And it's frequent to find microglia around PG positive cells. Those samples show those samples show high levels of neurodegeneration. However, something that really caught my attention was that the high compact DNA condensation in the nucleus of the neurons of these individuals. And also, I verified that observation, in other individuals, like you can see in the bottom. So some neurons show a dense granular cytoplasmic staining for PGG valleys, and others still have PGG valleys also in the nucleus that you can see in the individual for 47 years old. So after we decided to see samples for young individuals of having Down syndrome, and the most of neurons show intracellular gingiva accumulation, a low expression of the neural-specific enolase. Moreover, the DNA compensation was observed practically all neurons, and cytoplasmic DNA was evident, as is shown in the middle. The cellular membrane was irregular, with signs of leveling, and is shown with the arrowheads. And also neurons with low enolase expression show intracellular mature interleukin-1 beta, contributing to the inflammatory environment. So after we moved to see another model, and we see that marmoset cell samples at different ages, and we also were analyzed, and we observed the presence of the PGG valleys and the gingipines, the PGG valleys in red and gingipines in green, in neurons from the stratum radiatum and the stratum pyramidale in the hippocampus of marmosets. The magnification showed the gingipines mostly in the nucleus of neurons and PG in the cytoplasm. However, it showed that in the marmoset of 7 years, that is in the middle, the gingipines can be also visualized in the cytoplasm in the similar way that what is observed in humans. So you can see the violet arrowhead. Note that the massive loss of expression of the neuronal enolase in the female of 12 years old compared with the male that is the same age. So after we analyzed the temporal cortex to assess the degree of infection, and we found that the most of the parenchymal cells were gingipine positive, that it was around 80% of the total cells. Same as we saw in the hippocampus, gingipines are located mostly in the nucleus of the cells, principally neurons, but it's also possible to see them in the cytoplasm. So that you can see in the magnifications. So interestingly, the female, the 12 years old, have a chronic upper respiratory disease. So when we analyzed the glial reactivity, we noticed that the old female had a highly astrocytic reactivity compared with the old male. Almost every astrocyte is expressing G5P in the brain parenchyma. When we analyzed the hippocampus, we realized that microglial cells in the female were completely round and highly activated compared with the microglia in the old male, suggesting that an inflammatory disease could aggravate the brain infection of PGG valleys. So the conclusions of this work, the porphyromonas PGG valleys and the gingipines are observing the cortex and hippocampus of individuals with Down syndrome, and the PGG valleys level is higher in Down syndrome than AD samples. Older Down syndrome individuals, like less than 40 years old, over 4 years old, show high levels of neurodegeneration, extracellular DNA, glial reactivity, and clear astrocytic polarization. And neurons are highly infected with PGG valleys. So young adults with Down syndrome between 20 to 40 years old, they show PG infected neurons with DNA condensation, cytoplasmic DNA, intracellular gingipine accumulation, membrane leveling, and mature interleukin-1 beta. PG and gingipines can get access to the brain of marmosets. They can be found in the cortex and the hippocampus at different ages in a similar way to humans. And finally, preliminary results suggest that PG infection in an aged animal with an inflammatory disease produce an exacerbate glial activation, which could trigger neurodegeneration. So just to talk about implication of the future research, we know that cohort studies in patients affected by periodontal disease have shown that poor oral and disease severity represents a potential strong risk factor for the progression of cognitive impairment. Despite the strong evidence that from laboratory-based research and histopathological observations, the role of PGG valleys in the pathogenesis of Alzheimer's is widely underappreciated among the scientific community. Since periodontitis is a risk factor for AD, oral aging programs and PGG valley stereotype identification are essential to identify microbiological susceptibility. Those strategies could reduce the occurrence and severity of periodontitis and its consequence in other tissues or organs. Basic research of PGG valley serotype is fundamental to create new innovators for future treatments, especially in underrepresented or underserved communities that are disproportionately affected by periodontitis in AD, such as Down syndrome. And a creation of consortium of professional society between dentists and neuroscientists are crucial to exchange knowledge, associate symptoms, and explore new ideas. This is particularly important due dental evaluation and dentists have not been considered in the national dementia prevention policies in different countries. So I will just to say thank you so much to get your attention. And our collaborators are Dr. Naguib Meshawar in McGill University, Dr. Jaime Diaz-Zúñiga, University of Chile, and Dr. Natalie Seitouni, McGill University. Thank you so much.
Thank you, Dr. Munoz, for the very interesting presentation. I think we are open for the questions now. I will check the chat box to see if there is anyone with the questions. Well, I don't see any questions in the chat box, but I can, I guess, start. Anybody has any questions?
There's one question in the chat.
Oh. Okay. Oh, yes. The question is from Aaron Burberry, and it says, to what extent do P-gingival's reactive antibodies in AD patients cross-react with human self-antigens or other microbes present in the microbiome?
They're highly specific for PG.
So at least the antibodies that we are using at the lab, we're using some negative controls. We don't have any signal. And we are using 2 different antibodies for gingivalis, different companies, and another specific antibody against just the gingivines provided by the DSHB. I'm not pretty sure. I don't see any signal when I'm using the negative control.
I can attest to that. For our antibodies, we have the same results. They are very specific. Thank you for the question. Any other questions? Mike Wittek is asking, does treatment with gingipin inhibitors lower anti-PG antibodies and or PG levels in humans? I think this question is more specific to the area. If you think about the infection entropy where we are talking about, I think the question is directed maybe to the brain tissues, or it's hard to really answer that question.
I showed the serum PGG antibody dose response decrease in the presentation.
Okay, can you please answer that, Dr. Dominic? Thank you.
Yes, we did. I actually showed a slide where the PG PG antibodies were decreased in dose response graphic. Yes. So yes, we could measure that. We did.
And did you measure was it the saliva samples?
Saliva was PG DNA measurements, and the serum and CSF was IgG. Yeah.
Thank you for clarifying where it was. Thank you. Let me read the other questions. I think this is to Dr. Hajishanga. Oh, go ahead.
Oh, hi. Yeah, this is Ariel Tomasi. I just have a question to Dr. Dominic. By the way, very exciting presentation, very interesting results. I was wondering if you looked at ApoE genotype in these individuals, and if you noticed a difference in responsiveness to the PG inhibitor by ApoE genotype.
Well, we stratified also. We had a placebo arm, a low dose arm, and a high dose arm. We stratified patients that had ApoE, heterozygous or homozygous across arms to negate the effect if it's more pronounced. We're still analyzing this trial, by the way, and we actually are looking a little bit deeper in a more fine granular way at the ApoE effect, if there is one with this. But yes, that's a good question.
Thank you.
Thank you. There are some questions I see I can answer, maybe a few of them, maybe other speakers can do. There is a question if whether the different species, subspecies of Porphyromonas gingivalis may have less virulent properties. There are many decades of research on the various properties of P. gingivalis shown to be differentially expressed between the across the strains, substrains of subspecies of P. gingivalis. However, the ones that are mostly recognized for specific activities, at least in our laboratory, doesn't seem to be significantly differ. We do know, though, some species such as W83, 381 appear to be not as good as the 32277 type strain. Those are all type strains in terms of intracellular chronic survival. They seem to be much more competitive in the biofilm environment. That's sort of the answer, but it's a really difficult question in terms of having so many different properties in this particular microorganism. There's a question about can maladaptive immunity be measured in humans? This is to George Hajishangelis.
Yes, trained immunity can be measured also in humans. A lot of work has been done in that regard. The group of Professor Nedia in the Netherlands. For example, one can get, even from bone marrow cells, and analyze them for the epigenetic signature that underlies trained immunity. But also more practically, you could get, like I said, peripheral blood cells and stimulate whether they can respond in a more pro-inflammatory way than who have not been trained in that regard. Now, another thing that I would like to mention, I didn't have time to show experimental data, but this trained phenotype can be transmitted with bone marrow transplantations to recipient mice, and that suggests the potential issue with human bone marrow transplantations. We know that one of the critical ways for success, of course, is to find a compatible donor, but we have to have in mind that by getting even compatible bone marrow transplant, you inherit the inflammatory history of the donor. So this is probably something that needs to be considered in future human. Yes. So whatever can be done in mice, the short answer is you can also do it in humans in terms of measuring innate immune memory or trained immunity.
And there was a follow-up question maybe answered, George, to you, if your findings can be discussed in the context of APO4 gene. APO4.
No, we didn't in that regard. But in principle, like I said, I think that trained immunity or maladaptive trained immunity, because this is the dark side of this concept, at least in principle, it can relate any to inflammatory diseases through bone marrow being the central hub that mediates this association. But of course, this has to be empirically verified. So far, we have done this in the context of periodontal disease and rheumatoid arthritis.
So this question is, I think, Dr. Domini, how was PG status measured in saliva?
Good question. First of all, I wanted to, I think the one participant who asked about the ApoE4, I didn't quite understand the question. The question was about, did the ApoE4 positive people respond the same as ApoE4 non-positive people to the ginger pain inhibitor? The answer is actually yes to that. But we did stratify ApoE4 people across the three arms. We actually, we say saliva, but we actually use an oral rinse, and we worked with a company to do PG, qPCR, for the, PG DNA. And so it was quantitated in that manner.
Wonderful. And thank you, Mary Ellen, for the comment. I think the question was referring to the subspecies, the serotypes of the P. gingivalis, and thank you for highlighting P. gingivalis is really the one has the gingipains. Thank you. Let me see if we see other questions. Oh, there is a question for Dr. Movila. Sorry, Dr. Movila. Dr. Marek, do you see that question? Can you direct that if possible?
Yes. For Dr. Movila question, I did not know that A beta 42 and p tau could be measured in GCF. Is there a correlation between GCF and CSF measurements?
That is a great point, actually. We also didn't know that it could be measured. We measured and found in GCF, but unfortunately we didn't have actually JSF samples from the same patient. So it will be great to do it in the future. But the story about levels of amyloid beta and p-tau in GCF collected from periodontal lesions are under review now.
Thank you. I don't know, Dr. Yilmaz, did you ask a question from Dr. Merchant? How was PG positive status measured in saliva? Did we answer that?
I think Dr. Domina answered, but we have maybe if there are others would like to answer, please go ahead.
Yeah, well, yes, we measured PG in saliva using qPCR technique. We had a company that's experienced in doing that. It was done with the oral rinse, and then the qPCR then identified the quantity of PG DNA.
Thank you. Are there any other questions?
And if there are questions people would like to direct to speakers, please feel free to do so. And I'm also receiving individual questions and emails. Thank you everyone for joining, and really great kind remarks from everyone. I guess I will turn this to the organizers to make the final comments.
Thank you so much. Really wonderful session. Thanks everyone, all presenters and chairs, in really great discussion. There will be more opportunities for discussions and questions tomorrow and during our breakout sessions and the open discussion that we have at the end of the workshop tomorrow. So thanks everyone again. This is the end of day one, and hope to see you all again tomorrow for some more great presentations and discussions, and looking forward to tomorrow and to our breakout session as well. Have a wonderful evening, everyone.
Bye.
Thank you for the invitation.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thanks.
Hey, Camille. 60 Hershey.
Yes.
Did you get the closed caption broadcasting pop up on your screen?
Did I get what? Broadcasting?
The closed caption broadcasting just popped up on my screen.
Oh,
I think it's from Nicole. She's gone.
okay.
Yeah, she's gone.
Sure. We can chat more offline.
Yeah.
Yeah, hi, could I ask a question if you don't mind?
Sure, sir.
Yeah, so I was wondering about tomorrow. There's nothing